Dr. Premnath Mahajan sir also sent their best wishes for the program. We are extremely honored to have in our midst stalwarts in the field of ophthalmology, our guest speakers for today, Dr. Pavan Prashar sir, Dr. Anuradha Raj ma'am, Dr. Sahil Goyal sir, Dr. Anshul Thakur ma'am, Dr. Shafi Balwal ma'am, and Dr. Rohan Kapoor sir. We also welcome our guests of honor, Professor and former Head of Department of Ophthalmology, CMC Ludhiana, Dr. S.K. Chopra sir. Professor and former Head of Department of Ophthalmology and former Principal of CMC Ludhiana, Dr. S.M. Bhatti sir. I would also like to acknowledge the presence of our professors and faculty from the various departments of CMC Ludhiana present here today. We are grateful to all of you for gracing our event despite your busy schedules, and we hope to live up to your expectations. Now may I please welcome to the front our MBBS students who have prepared a musical invocation piece for us.
Worship His holy name.
you to our students for setting the atmosphere with that beautiful song. Before moving on, I would also like to acknowledge the presence of Dr. Neeraj Arora, who is the Secretary of the Ludhiana Ophthalmology Society, and Dr. G.S. Dhami is being represented by his young and enthusiastic son, Dr. Abhinav Dhami. Thank you so much for being with us today. Now, this day would not have been possible without the blessings of the Almighty, and to thank and invoke the grace of God, may I please invite Reverend Alex Peter to lead us in prayer.
Good morning, everyone. Such a beautiful morning. Bless the Lord, O my soul. Bless His holy name. I read from Psalms 19 and verses 1 to 4. The heavens are telling the glory of God, and the firmament proclaims His handiwork. Day to day pours forth speech, and night to night declares the knowledge. There is no speech, nor are there words. Their voice is not heard. Yet their voice goes out to all the earth, and their words to the end of the world. If you want, you can bow your heads and close your eyes. Give yourself in God's hand. Knowledge surely is God's gift for us. And wisdom, that's the biggest gift. Today when we are here in the Christian Medical College and Hospital, Ludhiana, let's thank God for the life of a stalwart, Dr. F.C. Eggleston, a strong administrator, a beautiful teacher, a mentor, and an excellent surgeon, who put forth the light of knowledge. And we are still carrying that torch forward. Heavenly gracious Father, thank you, Lord, for this beautiful day. Thank you for bringing all of us together in your presence, Lord. Lord, we are so thankful for this beautiful institution, our home called Christian Medical College and Hospital, Ludhiana, for its legacy of 129 years of mentoring, excellence, and also, Lord, leading young generations in your presence. And especially we are so thankful for each and every pioneer who served in this institution and become the light of wisdom and knowledge to the community. And especially we are so thankful for life of Dr. F.C. Eggleston. And today especially praying for Dr. F.C. Eggleston Memorial Trust, a trust formed to carry forward his legacy. We give each and every member, all the office bearers in your hands, Lord. And today, when this Dr. F.C. Eggleston Memorial orations are conducted here, we give all the dignitaries who are here. We give everyone who is going to lead us into different sessions. Lord, be with them, strengthen them. Through them, let this new generation be led into forward a beautiful future. Especially praying for Department of Ophthalmology when they are conducting and making all the arrangements of this memorial lectures. Be with each and every one of them, Lord. Together, their hard work be a blessing to every one of us. Lord, let you be our guide. Lord, let you be our strength. And let your blessings be upon us, now and forevermore. Amen. Thank you. God bless you.
Thank you, Reverend. Now, ladies and gentlemen, as we start with the function, may I please request the following guests to come forward and be seated on the dais. Our respected Director, Dr. William Bhandisa. Our worthy Principal, Dr. Jairaj D. Pandyan, sir. Our distinguished chief guest, Dr. Namrata Sharma, ma'am. Our esteemed medical superintendent, Dr. Alan Joseph, sir. The Honorable Secretary of the Dr. F.C. Eggleston CMC Ludhiana Trust, Dr. Navneet Kumar Chaudhary, sir. The Honorable Treasurer of the Dr. F.C. Eggleston CMC Ludhiana Trust, Mr. Piyush Kant Jain, sir. And Professor and Head of Ophthalmology, CMC Ludhiana, and the organizing chairman of today's oration, Dr. Nitin Batra, sir. Now may I request all the acclaimed guests seated on the dais to kindly partake in the very auspicious lighting of the lamp ceremony. And now, ladies and gentlemen, to start off with today's events, may I please invite the Honorable Secretary of the Dr. F.C. Eggleston CMC Ludhiana Trust, Dr. Navneet Kumar Chaudhary, sir, to deliver the welcome address.
Good morning, one and all. Honorable Chief Guest, Dr. Namrata Sharma ji, Professor of Ophthalmology at All India Institute of Medical Sciences, New Delhi, Dr. Vinay Bhatti, Director, Dr. Jairaj Pandyan, Principal CMC, Mr. Piyush Kant Jain, our Treasurer, Dr. Alan Joseph, Medical Superintendent, Dr. Parvez Javed Haq, current Head of Surgery Department, Dr. F.C. Eggleston Memorial Trust President, Dr. Sarjeet Singh Gill, who is watching this function live from USA, and he has sent his good wishes and blessings for today's program. Other members from abroad, Dr. Elizabeth Paul, who is president of US board, Dr. Seva Singh Lega, Dr. Anil Chabra, Dr. Kate Whitcomb. And our Indian members, Dr. P.N. Mahajan, Dr. Srish Chandra, Dr. Sidhu, and Mr. Piyush Kanjan. Distinguished guests, faculty for today's CME program, faculty from CMC, CDC, and allied colleges, press, students, ladies and gentlemen. I welcome you all for today's special event as we celebrate the life of Dr. F.C. Eggleston, the founder of Surgery Department at CMC Ludhiana. It is a great honor for me, as he is one of his students, to say a few words about this great personality. Dr. Eggleston graduated from the Princeton University in 1942 and received his medical graduation from the Cornell University, New York in 1945. He did his residency in surgery from the Columbia University and the surgical resident training in thoracic surgery at the Presbyterian Hospital, New York. He was a diplomate American Board of Surgery, diplomate American Board of Thoracic Surgery, and a fellow of American College of Surgeons. Dr. Eggleston was a US Navy World War II veteran too. His first assignment in India was at TB Sanatorium in Jubar, a small village in Kasauli Hill in Himachal Pradesh, about 200 kilometers from Ludhiana. While he was there, he was requested by Dr. Eileen Snow, then principal at CMC Ludhiana, to help her start the Department of Surgery at CMC. He took up the challenge and joined CMC as head of surgery department on the 1st October 1955. Dr. Eggleston started a modified American residency program in surgery here. He had a fiercely scientific outlook, and one of the first things he did was to establish a surgical research laboratory here, where animal experiments, especially those related with cardiovascular surgery, were performed routinely. Dr. Eggleston was pioneer in North India in introducing the use of intravenous potassium, peritoneal dialysis, blood gas and acid-base analysis, and use of ventilators in the care of sick patients. He initiated the program to develop various surgical specialties like cardiothoracic surgery, urology, pediatric surgery, plastic surgery, microvascular surgery at CMC Ludhiana, and pioneered open-heart surgery. The now common practice of having a separate branch of surgery to deal with the cancer patients, including the concept of tumor board, was in fact his brainchild and first put into practice at CMC in 70s. Dr. Eggleston also served as the director of hospital from 1982 to 1986. He was also the founder president of the Northern Chapter of Association of Surgeons of India. In a span of over 3 decades, from 1955 to 1986, Dr. Eggleston taught more than 1,300 medical graduates and trained more than 100 surgeons who were spread all over the world as excellent surgeons carrying out the rich legacy of their boss. He was a great teacher who constantly encouraged his pupils to keep the well-being of his patients as their main priority. His training and dedication towards surgery not only nurtured excellent surgeons, but also put the Department of Surgery on the world map. Dr. Eggleston was a man with wide range of interest. He was a voracious reader and had a formidable collection of books. He was very fond of music, hunting, and sports. The cultural side of his nature was not only well known, but it spoke much of his well-groomed personality, which complemented his unique leadership qualities. He was fondly addressed as boss by everyone, including his patients. The Christmas party of the department used to be fabulous and full of warmth. Much glamour to his efforts was added by his devoted and understanding wife, Mrs. Barbara Eggleston, who always lent her unflinching support to him. Mrs. Eggleston typed theses of all the surgical residents that boss supervised in his career, and that is a tremendous commitment. For more than 3 decades, the weekly journal club was held in the evening at their home, where she served tea and cake to the resident each time. Starting an oration in his memory itself speaks of love and affection he enjoyed among his students, colleagues, people he encountered. Dr. Eggleston retired in Mechanicsburg, Pennsylvania, USA. He cherished the spirit of CMC till he left for his eternal abode on 9th November 2016 at the age of 96. After his death, Dr. Sarjeet Singh Gill, who worked very closely with Dr. Eggleston in 50s and 60s here, along with alumni and the students who were trained under Dr. Eggleston, they decided to create something special in Boss's memory. So on June 11th, 2018, this trust was established. The aim and objectives of this trust are to promote the by various means, medical education in India in the memory of Dr. Eggleston. On 23rd March 2019, the trust organized its first oration, and the speaker was renowned laparoscopic surgeon Dr. C. Palnivellu, the founder president of Association of Minimal Access Surgeons of India and former president of Association Surgeons of India. For next 2 years, we could not hold the function because of COVID, and the second oration was held in 2019, last year, by Dr. Bashi V. Valaudan, Director, Institute of Cardiac and Advanced Aortic Disorders, SIMS, Chennai. Friends, we are indeed fortunate today to have amongst us Dr. Namrata Sharma, the Professor of Ophthalmology at Rajendra Prasad Center of Ophthalmic Sciences at Oration Institute of Medical Sciences, New Delhi, delivering the third Dr. F.C. Eggleston Memorial Oration. This will be followed by a scientific program, and for that, we have learned guest speakers, including Dr. Pavan Prashar, Dr. Anchal Thakur, Dr. Anuradha Raj, Dr. Sahil Goel, Dr. Shafi Badwal, and Dr. Rohan Kapoor, who will discuss and enlighten us on some recent developments in the field of ophthalmology. Keeping in line with Dr. Eggleston's noble idea of sharing knowledge and experience without boundaries, the academic activities of the trust will be without registration fees. Donations to the trust are welcome. The trust is grateful to CMC Ludhiana for its very kind and generous support for fulfilling its motto of furtherance in medical education. Once again, I extend a very warm welcome to all of you. Thank you very much.
Thank you so much, sir, for your enlightening speech. May I please call upon our respected director, Dr. William Bhatti, sir, to address our gathering.
Staff, students and faculty of CMC Ludhiana, our other esteemed guests, those who have joined us online, Dr. Gill and other members of US Alumni Board, I welcome you all on third Dr. F.C. Eggleston Oration. Today's oration is to remind us the contribution which Dr. Eggleston has fulfilled, which was set by our founder, Dr. Brown, in terms of patient care, education, and research. Dr. Navneet Chaudhary has already mentioned the contribution of Dr. Eggleston in terms of training and surgery department. But much more than that is, he responded to the call of mission work. While he was in his comfort zone in US, there was no need for him to leave his comfort and travel all the way from there to India and to Ludhiana. So he responded to that call. Not only that, along with that, his wife, Mrs. Barbara Eggleston, she also contributed in terms of education. She was actively involved in, I remember distinctly, in Ewing Christian School. She was manager when I was student over there. So that shows their missionary spirit to fulfill the vision and mission of Dr. Brown. Not only Dr. Eggleston, many more joined CMC Ludhiana because they took inspiration from Dr. Eggleston. As we know, his innovative approach in terms of surgical management of patients is remarkable. That motivated a lot of students to join field of surgery. And though I didn't get an opportunity to work with him, but at the same time, I had interaction and opportunity to learn from his students. So that speaks volume of his training. And I am grateful to FC Eggleston Trust, Dr. Sarjeet Gill and entire team for creating this opportunity for all of us where we can remember Dr. Eggleston's contribution. At this moment, I would like to thank, on behalf of CMC Ludhiana Board and Management, Dr. Namrata Sharma for accepting our invitation. It is another way forward as far as the motto of FC Eggleston Trust is there, furtherance of medical education. And I am sure today's oration will be full of learning for all of us, and it will motivate entire faculty and our students to move forward. Friends, let's utilize this opportunity and move forward on the legacy which Dr. Eggleston has established for all of us, and develop Department of Surgery, field of patient care and medical education. With that, I wish you all happy learning for today, and God bless you all. Thank you.
Thank you so much, sir, for such an insightful address. Now may I please call upon our worthy principal, Dr. Jairaj D. Pandian, sir, to enlighten us with his words of wisdom.
Dignitaries on the dais and our senior ophthalmologist from the city, Dr. Chopra, former HOD of ophthalmology, Dr. S. M. Bhatia, former principal and professor of ophthalmology, faculty from CMC, students, and faculty from CDC, College of Nursing and College of Physiotherapy. It's my privilege to welcome you all for this third Dr. Eggleston Memorial Oration. When I joined CMC in 1990, during my residency, I've heard about Dr. Eggleston's the teaching, his mentoring, and particularly innovation in surgical techniques and also in research, the surgical research. There were many stories that I had listened from his students who were teachers at that time. And one of the important things that he had introduced was a residency training program where house officers or house doctors are selected based on their interest in that particular field. And they went through rigorous training for 2 years. In surgery, it was so difficult. Sometimes people have to wait for 3 years to get into actual residency. Looking back, after the introduction of NEET, in the NEET program, there is no choice. If you have very high marks, you will get the area of your interest. Otherwise, you have to take whatever comes on your way. And recently, we had this stray counseling for PG. I was asking one of the students, what was your first choice? First choice was pediatrics, but she got into anesthesia because that was the one that she got in. So that has pros and cons. And if you look at the NEET, what it has done is, right from year 1 of MBBS, students are preparing for PG exam. The clinical skills are not there. The residents who come and join year 1, they are not able to put a simple intravenous line. This is not only here, it's across the country. Even in larger institutions like AIMS or PGI. And so that is what it has done. And recently, I think a few days ago, we concluded PG wellness program. And the stress of residency and how they cope, and the NEET, after the introduction of NEET, we are seeing so many problems among PG residents. They are not able to cope stress because they are just trying to crack MCQ exam, not facing patient. One of our students, year one, was unable to face an emergency of a patient. Suddenly patient worsened in the ward, not able to cope, went into panic attack. So looking back, the residency program introduced earlier, that really identified the right people for the specialty, trained them rigorously, and then they were very impactful in the society. And I congratulate the Department of Ophthalmology for taking up this oration this year with the theme, recent advances in corneal transplantation. One of the major public health problems in our country is preventable blindness. And there are many efforts that has been taken across the country by stalwarts in ophthalmology to reduce the burden of preventable blindness, and particularly this corneal transplantation, the advances that has happened, the revolution that has happened, which will reduce this burden across the country. I sincerely thank Dr. Namrata Sharma for coming, for accepting our invitation, and as she'll be giving this oration. So with this, I'll conclude. This is my best wishes on behalf of Eggleston Medical College. Thank you.
Thank you so much, sir. I would like to take this opportunity to acknowledge the presence of our renowned President of the Punjab Ophthalmology Society, Dr. Neelima Sodhi ma'am. May I also request ma'am to kindly come up on stage and address our gathering.
Good morning, the dignitaries on the dais, my dear friend, Dr. Namrata, my seniors, Dr. Chopra, he's sitting in front of me and blessing me, Dr. Nitin Batra, who's invited for this special occasion, and I really congratulate Dr. Nitin to hold this oration ceremony, and thank you, each and everyone, and I wish you and congratulate you once again, and hope all these programs keep going on, and we all get benefit from such good orations, especially from Dr. Namrata regarding our corneal transplantations. Thank you, each and everyone, for inviting me here. Thanks a lot.
Thank you so much, ma'am, for your words of encouragement. Now may I please call upon Professor and Head of Ophthalmology, CMC Ludhiana, and the organizing chairman of the 3rd Dr. F.C. Eggleston Memorial Oration 2023, Dr. Nitin Batra, sir, to introduce our distinguished chief guest to our August gathering.
Good morning to all the esteemed guests on the dais and the distinguished audience gathered here today for the 3rd Dr. F.C. Eggleston Memorial Oration 2023. I have the unique honor and privilege this morning of presenting to you one of the most acclaimed, respected, dynamic, and well-known ophthalmologists in our country, whose reputation and accomplishments have broken borders and barriers and made her a well-known international star, head and shoulders above the best of the best. She continues to be an inspiration to all ophthalmologists and is known for her sharp memory, her wit, her dexterity, and humility. Quite simply, Professor Namrata Sharma, in charge of the Cornea, Cataract and Refractive Surgery Services at the RP Center, AIMS, New Delhi. Dr. Namrata did her post-graduation from RP Center, AIMS, New Delhi, and then she did her fellowship from the Moorfields Eye Hospital in London, UK. She is the Regional Secretary of the Asia Pacific Academy of Ophthalmology. She is the Chairman of the Scientific Committee of the All India Ophthalmological Society. Her clinical work includes phacoemulsification surgeries, foldable IOL, excimer laser, LASIK, PRK, small incision lenticule extraction, that is SMILE, and phakic intraocular lenses. Her keen areas of interest are corneal transplantation, including lamellar surgeries, that is DOLC, DSEC, and DMEC, anterior segment reconstructive procedures, ocular surface surgeries, and keratoprosthesis. Her area of research include all aspects of corneal diseases, including keratoconus, Fuchs dystrophy, chemical injuries, corneal ulcers, and Stevens-Johnson syndrome, along with cataract and refractive surgeries, as well as laboratory-based stem cell-based therapies. There is a long list, but I will go on about the international awards. She has 2 patents to her name, that is for Natasol and Natamatrix. She is the brand ambassador for the Tear Film and Ocular Surface Society in India, research committee member of the Asia Pacific Academy of Ophthalmology, honored as one of the 100 most influential female figures in ophthalmology in the world in the year 2021, and that is not all, one of the 1,000 Indian scientists coming in the top 2% scientists of the world by Stanford University. Dr. Namrata was also counted among the top 100 most influential ophthalmologists 2022 by the Asia Pacific Journal of Ophthalmology, APAO Senior Achievement Award, Best Paper by the American Academy of Ophthalmology, Distinguished Service Award by Asia Pacific Academy of Ophthalmology, the Leader Award also by APAO, Senior Achievement Award by the American Academy of Ophthalmology, the Achievement Award also by APAO, the Best Video by the European Society of Cataract and Refractive Surgery. She's also got the Best Video from the Royal Australian and New Zealand College of Ophthalmologists, Best Paper Presentations at the American Academy of Ophthalmology, Best of the Show 6 times by the American Academy of Ophthalmology. Among the national awards, she has the Best of the IGO certificates, that's the Indian Journal of Ophthalmology for the year 2022, IGO Certificate of Merit for the year 2022, and then the Dunes Iron Lady of the Year, that is by the judge's choice, awarded the Asian I. Palkaris Oration Award, awarded the Mudassar Dawood Mullah SAO Award for Leadership. She has delivered a college lecture on microbial keratitis, beating the bugs, at the 30th Annual Congress of the College of Ophthalmologists in Sri Lanka. She has received the Major S.C. Dutt Memorial Oration Award in West Bengal, the Global Influencer of the Year Award by the International Society of Manual Small Incision Cataract Surgery, the Dr. Vinod Arora Oration Award at the 13th Uttara Icon, Mrs. Tahira Agarwal Gold Medal of the Intraocular Implant and Refractive Society, that is the IIRSI, the Dr. Rustam D. Ranji Rotary Award in the lecture in 2021, the first Professor M. Prabhakaran Memorial Lecture for PG's Award by the Kozhikode Ophthalmic Society, and I could go on and on. Ma'am has 599 publications in international peer-reviewed journals. 119 book chapters she has been authored by her, along with 18 books to her credit, including corneal transplantation, corneal ulcer, step-by-step LASIK surgery, phacoemulsification surgery, decimal stripping, automated endothelial keratoplasty, different strokes, textbook of pterygium surgery, ocular infections book called the Ophthalmology Clinics, and it is specially targeted at the postgraduate students. She has been conducting numerous instruction courses and has been invited as the faculty in various national international conferences, especially the American Academy of Ophthalmology, American Society of Cataract and Refractive Surgery, the European Society of Cataract and Refractive Surgery, and of course the All India Opthal Society. Ma'am has held several administrative posts too, along with her achievements. She has been the former General Secretary of AIOS, the former Secretary of Delhi Opthal Society, and the former Secretary of the Eye Bank Association of India. At present, she holds the Chairman of the Scientific Committee, All India Opthal Society post. She is the President of the Cornea Society of India, Vice President of the Eye Bank Association of India, the Vice President of the National Society for Prevention of Blindness, which has its headquarters in RP Center, AIMS, Regional Secretary of Asia Pacific Academy of Ophthalmology, General Secretary of RP Center of the Research Association, Chairperson of the Scientific Committee of the Indian Society of Cornea and Keratorefractive Surgeons, and Chairperson of the Academy and Research Committee of RP Center, AIMS. This list can go on and on. I am pretty much breathless, as I can see. So now I have the honor to call upon Dr. Namrata Sharma, the shining, shimmering star of today's morning and the prestigious event, to receive the third Dr. F.C. Eggleston Memorial Oration 2023 medallion from our respected chairman, Sir Dr. William Bhatti, Dr. Navneet Chaudhary, the Honorary and Mr. Piyush Khan Jain, who is the Honorary Treasurer. We take great pleasure today and pride as we felicitate the one and only Dr. Namrata Sharma. Thank you, ma'am. And sirs, we are waiting for your presentation, ma'am, now with palpable excitement in the auditorium, and I request all the distinguished guests to kindly take their seats in the audience now, so that we may begin with the third Dr. F.C. Eggleston Memorial Oration.
you duplicated it. So respected Dr. William Bhatt, Director, Dr. Jairaj Pandian, Principal of the College, Dr. S.S. Gill, the President of the Board of Dr. Eggleston, Dr. Ellen Joseph, the Medical Superintendent, Dr. Naveen Chaudhary, the Secretary, Mr. Piyush Kumar Jain, the Treasurer of the Board, other members of the board members of the Trust, Dr. Nitin Batra, my very good friend and the organizing chair as well as the head of the Department of Ophthalmology, Dr. Haq, the head of the Department of Surgery, Dr. Chopra sir, who is sitting here, and I've known him since I've known ophthalmology right from my postgraduate days, because he was a examiner in RP Center Ames for all the batches. Dr. Neelima Sodhi, my very good friend, and now the president of Punjab Ophthalmological Society. Dr. Bhati, our own dear, again, friend and former principal as well as the head of the department. Faculty members, my very dear students and friends. It is truly an honor for me to be standing before you and giving this third Dr. F.C. Eggleston Memorial Oration today. More so because his life has been so inspiring and he has been so passionate about teaching, and the fact that he started the first surgical research laboratory is something which is very intriguing in those days when I think nobody even had any idea of research laboratories. So thank you so much for this honor, and I'm truly humbled. And thank you, Dr. Nitin, for that introduction. And it was too long, but it was not, I mean, it was my entire life, so that's it. So I would be talking to you about corneal transplantation, which is truly gone through a revolution in the recent times. And I have no financial or proprietary interests in the instruments and the equipment that I would be talking to you about. Why is corneal transplantation important? Because it is the major cause of blindness in our country in the younger age group. Younger age group means between 0 to 50 years. It is the commonest cause of blindness. And it is the second commonest cause of blindness, only second to cataract in our country. Now, cataract is something which is reversible, which can be treated, but corneal blindness at all times may not be reversible and can be treated by corneal transplantation if the cornea becomes opacified. We require 2 lakh corneas every year, and we collect only 52,000 and transplant 25,000. To this, we add 50,000 cases a year, and so there's a huge disparity between what we collect and what we transplant. There is a long wait for many, and this includes not only the older people, but also includes children, some of them whom are bilaterally blind. Now, I know that there are a lot of people who are not into ophthalmology also in this room. So normally, our cornea would look like this, and this is the pupil or the black, which you see in the center, through which we all are able to see. But if your cornea becomes white due to any cause, which could be due to trauma, due to infection, due to chemical injury, then all you need to do is replace that cornea. So you have to remove that whitish looking cornea, take a donor cornea, and then suture it, which actually would shine like a petri dish or like a glass, which is transparent, through which you can see. There are various layers of the cornea, and in fact there are 6 layers of the cornea, and earlier what we were doing is that we would replace the entire cornea irrespective of which layer the disease in. But now what we do is that we only do a layer by layer replacement without having to replace the entire cornea. Now, this is just a small video to show that when you have to actually retrieve the cornea, it is a very simple procedure, and all that is done, this is a cornea which is being retrieved from the deceased. The corneoscleral rim, or the outer part of the eye, is the only thing that you take, because that is the only part that can be transplanted. So after this is removed, this can be placed in the preservative media, and nowadays it can be preserved for as long as 10 to 14 days, and this cornea can be used. However, given the waiting list that we have in our country, we don't wait for 10 to 14 days because there's always patients who are waiting to be transplanted. So this is just to show that this is a simple procedure, and you then place a prosthesis and close the eye of the deceased, so it doesn't cause any disfigurement when you retrieve the cornea. So we have been doing a full thickness penetrating keratoplasty or corneal transplantation for the last 118 years, and this is a time tested technique because we are all familiar with it as surgeons. This is how a penetrating keratoplasty is done. This is a case of keratoconic cornea where there is opacity which is present in the center. So you do trephination, which is full thickness. That means the entire 500 microns of the cornea is removed, which is diseased, and then a clear cornea is taken from which has been donated by the donor, and this is sutured with 10-0 monofilament nylon sutures. Now, sometimes you can have cases like this, and this is because of infection. The cornea has melted, and in this case, again, the trephination is being done. All the exudates or the infected material are being removed first, and then subsequently the membranes which are present and which are obscuring the lens are also removed, so the patient is able to see. And again, a full thickness cornea is taken, and this is sutured with 10-0 monofilament nylon sutures so that the patient is able to see post-operatively. Now, sometimes the entire cornea is not affected, it is only the part of the cornea that is affected, and so in this case you would have to tailor your graft in such a manner that it fits the tissue completely and is complementary to it. So this is the corneoscleral rim, and in these blue marks that you see are the marks of the crescent graft, crescent-shaped graft, and these are then sutured onto the host so that it gives tectonic stability to the cornea of the host or the recipient in the post-operative period. So this is to show the pre and the post-op picture of the same. Now, sometimes you can have conditions like this where you have a perforation in the cornea and the iris is coming out through that perforation. So all that you do is that you push the iris back and again suture a little piece of a cornea there, which is again full thickness. So there are various ways in which this corneal transplantation can be done. Most of them would require sutures, and with this would be suture related problems because the sutures can become tight, they could be tight, they could become loose, they could attract mucus, they could attract infection. So these are the problems of a full thickness graft where you have actually used sutures. Sometimes there can be rejection because the entire cornea is being replaced and it is a foreign tissue for the host, so there is rejection as is seen here, and this is a total rejection and this is a focal rejection where it is occurring only on one side. For this, of course, topical steroids have to be given and it does reverse in most of the cases. Then, of course, when you do a full thickness graft, there can be infection which can even travel at the back of the eye, causing endophthalmitis. And sometimes when you do a full thickness corneal transplant where sutures are there, the graft is clear, but because of the suturing, there could be a little bit of change in the refraction or the cylinder, and there could be astigmatism which has to be addressed. And I think this is the most ominous complication which can occur in a full thickness graft, and that is when you're waiting for the donor cornea to be sutured. If the pressure rises, then there can be an expulsive hemorrhage such as this, where the entire retina, the vitreous and the intraocular contents are coming out along with the choroidal hemorrhage. So this I've seen only once in my entire career, but I'm showing it here for all those people, all those ophthalmologists who've not seen expulsive hemorrhage as to what can happen. So we've moved from an older era of overkill therapeutics where we were just doing a full thickness graft for everything to a more customized component surgery approach of the cornea where we are now replacing layers, and this is truly a revolution. So when you do anterior lamellar keratoplasty and when the interior layers of the cornea are affected, then you can do either automated lamellar therapeutic keratoplasty or a deep lamellar keratoplasty. And when the posterior layers, such as this green layer, which is diseased Descemet's membrane and endothelium is affected, you can leave the anterior part of the cornea of the host like that and only replace the posterior layers. This is the instrument which has truly brought about a revolution in which we do corneal transplantation. And this is the microkeratome which splits the cornea, and we do automated lamellar therapeutic keratoplasty with this instrument. Earlier we were dissecting the corneal layers manually, but with this instrument it has become technically easy, is less time consuming. There's a smooth host donor cut. The thickness is nearly exact and there are no interface problems. So you can have problems, anterior problems in the cornea like this. You can have a keratoconus or a Salzmann nodular degeneration, spheroidal degeneration, or a dystrophy which happens right from the birth. So this is the way we deal with the anterior opacities. That means this is the corneoscleral rim which has been put in artificial chamber, and then subsequently the microkeratome is being used. You can see 350 is written, so the entire 500 microns of the cornea is split into two, 350 and 150. And this anterior part is being used to deal with the keratoconic cornea, which is diseased. So again, this is the recipient bed in which the anterior layers of the cornea are removed, and the healthy split cornea, anterior split cornea, is taken from the donor and is sutured again with 10-0 monofilament nylon sutures. So because you are actually creating an interface there, it is there between the two, that means the host and the donor, but this interface is quite clear. And these are some of the cases: healed keratitis, Salzmann nodular degeneration, and keratoconus, to show how this ALTK surgery helps. Now, if the opacity is deeper, that means it is still deeper, involves the anterior and the mid stroma, then you can do what is called as the deep anterior lamellar keratoplasty, which allows the maximal removal of the diseased tissue, and this Descemet's membrane is there, which acts as a smooth graft bed, and there is no interface because this Descemet's membrane is very thin. This can be done for cases of keratoconus, ectasias, stromal dystrophy, desmetoceles, etc. And in these cases, because the Descemet's membrane and endothelium is clear and of the recipient or of the host, you can take a donor tissue which doesn't have very good endothelium and also do this surgery. Again, this is a case of keratoconus in which partial thickness trephination is done, and then we are injecting air to cause the separation of the corneal layer, especially the last corneal layer, which is the Descemet's membrane and the endothelium. And in this cross section also you can actually see that there is air which is present, and we are in the supra-Descemet's membrane compartment, and as you give a nick in the overlying stromal layers, you can see that this Descemet's membrane is marching in a live show towards these stromal layers. And then subsequently all we have to do is just reinforce this plane with the help of the viscoelastic and do a dissection over the Descemet's membrane and the viscoelastic cushion. So you can see that this Descemet's membrane is still there. We have not entered the eye. So if we have not entered the eye, we are still extraocular and not intraocular. We obviate all the problems which are related to the inside of the eye, such as cataract, secondary glaucoma, and expulsive hemorrhage that I showed you, because we are actually working outside the eye. And this is a case of Hurler's syndrome, a bilaterally blind child who came to us. We did a deep anterior lamellar keratoplasty, and this is now more than 15 years of follow-up when the sutures have been removed and the patient sees well, almost near normal with both the eyes. And we've not entered the eye at all. We were extraocular because we did a deep anterior lamellar keratoplasty. These are again some of the cases to show the same. Now there could be times when you do have opacity in keratoconic or cylindrical corneas. You can't put air because that will not traverse through the scar. So you just do a layer by layer dissection as is shown here. So even if the opacity is present a little paracentral, it doesn't matter, and the opacity is present somewhere here, but your pupil is absolutely clear, and from here is the area that you see. So you can still do a deep anterior lamellar keratoplasty without actually having to penetrate the internal portion of the eye. And these are again, this was a case of chemical injury, and then we have replaced the cornea, bilaterally blind patient again, and we did similarly in the other eye also. This is a case of dermoid, the golden hour syndrome, which has other features also systemically. A one-eyed patient, the other eye had phthisis bulbi, And now this gentleman has grown up to be an engineer with his only seeing eye, which has a visual acuity of 6/12. Sometimes you can have shapes of the cornea which are a little different, and this is a globular cornea where not the center, not only the center, but the periphery is also involved. So in those cases, we do a procedure which we call as the tuck-in lamellar keratoplasty procedure, because the central part of the cornea is not thinned out. It is the peripheral part of the cornea which is also thinned out. And this is the surgery that we've described, and we do this, and this was awarded by the American Academy of Ophthalmology as the best of show. So essentially what is done in a case of keratoglobus, as we call it, is that we do lamellar dissection, and then we make a pocket all around as is shown here. So we've again not entered the eye. This is the full thickness cornea of the donor that we take, and we punch it from the posterior side and remove a little bit of tissue, about 2 millimeters in the periphery, and then subsequently we put this tissue onto the cornea and tuck the peripheral part of it into the pocket that we had created. And so we've not only reinforced the center but also the periphery. So, and we've not done a full thickness graft, which earlier we used to do in these cases. So this is how the patient looks in the post-operative picture. So they have a huge bulge, but this bulge disappears as you suture the cornea and you do a tuck-in lamellar keratoplasty. Now here only the peripheral part is being thinned out. So we've made a flange only in the periphery, in the periphery sectorally, and not made the flange all around 360 degrees. And again, we are suturing this flange in the part which was thinned out in the periphery. So this is truly this is a true customization. Otherwise, if left to the olden era, we would just replace the whole cornea and use a larger graft without a tuck-in procedure. So this is because we've done this, we've actually reinforced the periphery. This is how it looks, but this peripheral part was thinned out, which is now tectonically stable. This patient also had cataract, and the cataract surgery was also done, and this is how the patient looks now with a visual acuity of 6/9. Now sometimes you can have complex cases. Radial keratotomy has been done, transverse keratotomy has been done. The patient has a distorted cornea and has a cornea which has to be regularized or smoothened, and again a tuck-in lamellar keratoplasty like this is done so that the patient has good visual acuity. Coming to the posterior part. Now, posterior lamellar keratoplasties are the surgery where we are only replacing the posterior part, because the anterior part is relatively healthy and is relatively clear. So when we replace the Descemet's membrane with the Descemet's membrane, little bit of stroma and the Descemet's membrane, we call it DSEC, that means Descemet's stripping automated endothelial keratoplasty. And when we replace Descemet's membrane which is diseased with only Descemet's membrane which is healthy, we call it DMEC, that means Descemet membrane endothelial keratoplasty. So we've moved from an era where we would suture the grafts to an era where the grafts are completely sutureless now. So all the suture-related problems are also gone, and we are not suturing our grafts as of now. So these are some of the cases where the anterior part of the cornea of the patient is completely clear, but the posterior part is affected, and that is why it has led to an edema which is present in the entire cornea. So this could be because of congenital causes, it could be after cataract surgery also, if damage to the endothelium has occurred, and also after various other surgeries. The advantage of doing these surgeries is that in a normal full thickness transplant, it would take 12 months for the patient for rehabilitation, but in these sutureless transplant, such as DSEC, it takes 3 months, and now with DMEC, it takes only 1 month for the visual rehabilitation to occur. Also, because you are only transplanting a layer and not the entire cornea, the chances of rejection are much less. Now again, to show you the same, this is the corneoscleral rim which has been taken. This is going to be split, placed in the artificial anterior chamber. This is how it looks like, the full thickness one, which is 550 microns. So we are using a 450 microns microkeratome head. So we've split the cornea, so the anterior part can be used for anterior lamellar keratoplasty, and this posterior part, which is about say 100 microns or 70 microns, can be used for posterior lamellar keratoplasty. So that is how we use one cornea for 2 patients. Now, the posterior part that is split is loaded, is trifinated and loaded into what we called as the Buson's glide, and then subsequently this will be pulled intracamerally inside the anterior chamber so that you do a posterior lamellar graft or a dissect without actually having to do a full thickness corneal transplantation. So this is a case of pseudophakic bullous keratopathy, and in this you can see in the side view also in the operating microscope that we are pulling the stroma as well as the Descemet's membrane of a healthy cornea, and then subsequently we will inject air. So as you inject air, this graft, which consists of Descemet's membrane and stroma, will get stuck to the back of the cornea. And once you give healthy endothelium and stroma to the recipient, this cornea will start clearing in the post-op period. So this is how we do a Descemet stripping automated endothelial keratoplasty, and we don't use sutures in these cases at all. This was our publication on DSEC, and we've used now one donor cornea for 3 recipients. So this one donor cornea, this was a case of keratoconus. We did anterior lamellar keratoplasty. Then from the same donor cornea, we did DSEC, which I just showed you after splitting the cornea, and this is a sutureless transplant. And from the limbus, you can do a limbal stem cell transplant also. So if a person donates, then actually you can benefit 6 recipients. Because even if one eye of a bilaterally blind is rehabilitated, the person is able to carry out his daily activities. So hence the importance of donation of the corneas. We've also used the donor cornea, one cornea for 2 recipients. That means we use it only for the anterior and the posterior lamellar keratoplasty. Now this is truly a revolution, because here the Descemet's membrane of the cornea is being removed, which is the last layer, which has endothelial cells and which is actually responsible for the clarity of the cornea. So we've stained the Descemet's membrane of the healthy donor cornea with the help of the trypan blue dye to visualize it, and the graft is being fashioned. This is hardly a 10 to 20 microns membrane. We stain it with trypan blue dye so that we are able to see it, and this is now what we are going to implant for a diseased Descemet's membrane which is there, which has caused haziness of the cornea. So we are decreasing the size of the grafts, and so the chances of rejection are much less and visual rehabilitation is much faster. Now this was a case which had a diseased Descemet's membrane because of Fuchs dystrophy. So the cataract surgery is already done in this case, and we are removing the diseased Descemet's membrane by doing the Descemet membrane stripping with the help of the reverse Sinskey hook. And this is the Descemet membrane graft that we had fashioned, which I had shown you in the previous slide. This is injected into a syringe or an injector, and this is then placed inside the eye. And once this is placed inside the eye, we get the correct configuration up, and this is it has to be like this. That means the biceps curl has to go upwards. Now because the endothelial side is the one which has to face down. So this is an absolutely inverted graft, and when you have this configuration where your biceps curl is upwards, which you can see now, then you can be sure that the endothelium is down, and then just with the help of the air bubble is instilled, the graft has got stuck to the back of the cornea. So this is the latest in the armamentarium of corneal transplantation, and this is how the patient looks like on the post-operative week 1, and this is at post-operative month 1. Even your fellow ophthalmologist will not be able to make out that there is a thin graft there unless he watches very closely, because this is just a 20 microns graft. He would probably think that only a cataract surgery has been done, but it is not so. So we have published our results on this as well, and the outcomes after this surgery are very good. The primary graft failure rates are very low for this, because you are only implanting a very thin membrane, and the visual acuity is very good because there are no sutures. It's a graft which has got stuck on its own by using the air bubble. So this is just to show how one cornea was used for 2 recipients, the anterior one for deep anterior lamellar keratoplasty. So this was a keratoconic cornea. We split the cornea and used the anterior part for the deep anterior lamellar keratoplasty and the posterior part for the DMEC. So that is how we can benefit more than one patient. Now, so if you see the evolution of the various grafts, full thickness graft had endothelial cell loss of 25 to 28%. DSEC and DMEC that I showed you, DSEC would be with stroma, DMEC would be only with the Descemet's membrane endothelium, has comparable endothelial cell loss. But important thing is that the rejection rates are far less. So for a full thickness graft, it will be 21%. For DSEC grafts, because it has little bit of stroma, is 7%. But for a Descemet membrane roll, which I showed you right in the end, it is only 1%. Now, this is something which we are working on, and this is something I think which is going to be the future, and that is the biosynthetic cornea, because we don't get human donor corneas. So in our laboratory, we are working on a synthetic material which can substitute the cornea, and this is nothing but clinical grade collagen type 1, and this has been doubly cross-linked. This is how it looks like, which is possibly like a contact lens, a soft contact lens that people use. It has 500 microns thickness. It is 12 millimeters diameter. When in bottle, it is for 2 years, but we now have a follow-up of more than 7 years in our cases with good results. And it is a transparent structure, and it maintains its transparency. It has gone through all the optical checks that are required, the in vivo biocompatibility, in vivo evaluation, ex vivo analysis in mini-pig keratoconus model, and even the scanning electron microscopy has been done by our team at All India Institute of Medical Sciences, except for the fact, because it's obtained from pig's collagen, the fibrils are a little broader, but otherwise it looks pretty much like the human tissue. And this is how your normal cornea would look when it is implanted or sandwiched in the stromal layers, and this is how your synthetic cornea would look. The only difference is that it is acellular, it doesn't have cells into it. Of course, this is the confocal microscopy, which is the imaging of the synthetic cornea, and it doesn't have cells, it is acellular, but above it and below it, when you sandwich it, the cornea maintains the layers maintain their viability. Now, this is how it is implanted, and this is a keratoconic cornea where we are making a pocket with the help of the femtosecond laser, and we then open this pocket. We need to do corneal transplantation in these eyes because the corneas are very thin and they are conical in shape, and this, by its splinting action, would take care of the shape of the cornea as well as would also increase the thickness of the cornea. So after we make that pocket, this is the synthetic cornea, and this is folded just like we used to fold our intraocular lenses in the olden days. This is placed inside the pocket as is shown here, and then subsequently unfolded, and a bandage contact lens is then placed on it. So we don't require any sutures at all. So this is how it looks in the post-operative period. This is the sandwiched biosynthetic cornea, which was intrastromally implanted. And we are actually shifting to intrastromal keratoplasties in such cases where tectonic stability is required. The keratometry or the shape of the cornea is coming near normal. So once you have this red-looking area in the pentachem maps or the maps where we look at the corneal topography, it means that it is abnormal, and once this red color disappears, as is shown here in the post-operative picture, it means that it is nearing normal. So the post-op keratometry here is 50 diopters. In the pre-op, it was close to 90 diopters, and from 240 microns corneal thickness, we have increased it to 580 microns of corneal thickness. We have now done this in more than 55 eyes with a follow-up of 7 years, and there has been no rejection, inflammation, vascularization, or scarring in any of the subject. So if we are able to develop this further and use this, I think we may not require in future. Of course, this is far-fetched, but we may not require in future the eye banks, the eye bank personnel, or the instruments and the preservative media that is required for human donor cornea. We have, as of now, a stromal construct, which is a new frontier, which I showed you. But the next level, we are working in our laboratory at ORBO, All India Institute of Medical Sciences, is that we are trying to grow endothelial cells on this biosynthetic cornea so that you have a complete corneal construct. And this publication on the bioengineered corneal tissue for visual rehabilitation in advanced cases of corneal ectasias. We did this study in collaboration with our Swedish collaborators, and this was published in Nature Biotechnology, which has an impact factor of 68.1. We had collaborators from Iran as well as from Sweden, both in this study. So I think this should be the future, where just like you use intraocular lenses and implant them in patients' eyes, we should be opening the bottle and using the synthetic corneas rather than having to use corneas and retrieve corneas from the diseased donors. Another thing that is really revolutionizing is that people are working on the cultured cells with the ROCK inhibitors, and that should be in the form of injections. Dr. Kinoshita's group is doing a lot of work on this, and this is just to show the preliminary results of the same in clinical studies. Although it cannot deal very severe cases, but for mild cases, this technique does well. And I would conclude by this last small video. I call it 2 Eyes, 2 Lives. Is there an audio in this? Is the audio lead connected? Okay, it doesn't matter. It is connected. Okay. So sometimes you can make, no, it is not connected, make a lot of difference in the way, I think here you have to do it. Okay, even if it is, yeah, now it will come. Just increase it, yes. Sometimes you can make a difference in people's lives, and this is just to show the same. So this was a 28 weeks pregnant lady with bilateral peripheral ulcerative keratitis. And you can see that both eyes were like this when she came to us, and she had 28 weeks of pregnancy. So there were obstacles because the patient was not cleared for surgery. We had to do a therapeutic penetrating keratoplasty, otherwise the corneas would melt and she would lose vision forever. So in view of the high chances of preterm labor, because if you give general anesthesia, this can happen, and also because of the fetal maturity, was not sure whether the fetus would be mature or not, we had to take help of our other departments in AIMS. And IV steroids injections were given for fetal lung maturity, and then ophthalmologist, neonatologist, obstetrician and anesthetist, everybody was roved in. And the fetal monitoring while we were doing the surgery was being done by the neonatologist. Obstetrician was there lest there is some preterm labor, and this is the surgery that we are doing under general anesthesia. So we did one after the other, but I'm showing you together to save time. So all the membranes that were there were removed and the dissection was done, and full thickness corneal transplants were placed in the right eye as well as in the left eye. We had to use 12mm donor cornea because it was very large perforation in both the eyes, and this was then sutured. Now she came totally blind, accompanied by her husband, but 2 months later, this is how she looked. And we were able to rehabilitate her bilaterally by bilateral corneal transplants and with good visual acuity. And she came alone with her child, and this is how, and she was able to see the child, which she feared that she would not be able to see earlier. So this is the beginning of a new life, 2 eyes and 2 lives which were simultaneously saved. So to conclude, lamellar keratoplasty today is the component surgery of the cornea, and I think layer by layer visual rehabilitation as far as the corneal transplantation goes is required. Biosynthetic cornea is a reality, and I'm sure it is going to be the future, so that we don't have to depend on human donor corneas. And pharmacological treatment in the form of drops should come eventually so that it causes clearing of the cornea. These are our books on corneal transplantation, DALC and DSEC. And this is our mission. Of course, 2 lakh in 2025, I don't see it happening, but we have to change our goal of obtaining donor corneas 2 lakh possibly in 2030. Thank you very much for your kind attention.
Thank you so much, ma'am, for that incredibly impactful oration that has left all of us totally captivated. And your words are definitely not to be forgotten. The organizing committee of the third Dr. F.C. Eggleston Memorial Oration 2023 would like to extend its gratitude to the distinguished guests with whose encouragement and support all of this has been possible today. May I please call upon Professor and Head of Ophthalmology, CMC Ludhiana, and the organizing chairman of today's oration, Dr. Nitin Batra sir, to commence the felicitation. I request our respected director, Dr. William Bhatti sir, to kindly come forward. Our esteemed medical superintendent, Dr. Alan Joseph sir. May I please request our director, Dr. William Bhatti sir, to please join Dr. Nitin Batra sir to felicitate our guests. I invite the acclaimed member trustees of the Dr. F.C. Eggleston CMC Ludhiana Trust to come forward. The Honorable Secretary, Dr. Navneet Kumar Chaudhary sir. The Honorable Treasurer, Mr. Piyush Kant Jain sir. An acclaimed member trustee, Dr. Parvez David Haq sir. I invite our guests of honor, Professor and former Head of Department Ophthalmology, CMC Ludhiana, Dr. S.K. Chopra sir. Professor and former Head of Department Ophthalmology, CMC Ludhiana, and former Principal of CMC Ludhiana, Dr. S.M. Bhatti sir. We would also like to present a token of appreciation to our renowned President of the Punjab Ophthalmology Society, Dr. Neelima Sodhi ma'am. Now may I please call upon our excellent guest speakers for today, Dr. Pavan Prashar, sir. Dr. Anuradha Raj, ma'am. Dr. Sahil Goyal, sir. Dr. Anshul Thakur, ma'am. Dr. Shafi Badwal, ma'am. And Dr. Rohan Kapoor, sir. We would also like to present a token of appreciation to Dr. Neeraj Arora, ma'am, Secretary, I beg your pardon, Dr. Neeraj Arora, sir, Secretary of the Ludhiana Ophthalmology Society. And Dr. Abhinav Dhami. Okay. Thank you, ma'am. Thank you, sir. Now may I please call upon Dr. Gurvinder Kaur, ma'am, Professor from the Department of Ophthalmology, CMC Ludhiana, to deliver the vote of thanks.
On behalf of Department of Ophthalmology, I take this privilege to thank our respected director, Dr. William Bhatti, our worthy principal, Dr. Jairaj Pandian, and our respected medical superintendent, Dr. Alan Joseph, for their support, guidance, and encouragement. I would like to thank the worthy members of Dr. F.C. Eggleston CMC Trust, Dr. Navneet Chaudhary, Dr. Premnath Mahajan, Dr. Sirish Chandra, Dr. Gurdeep Sidhu, Mr. Piyush Kant Jain, and Dr. Parvez David Huck. Thank you for having faith in us for organizing this oration. I thank our respected PMC representative, Dr. Apchinder Kaur, for gracing this occasion. I would like to thank our esteemed chief guest, Dr. Namrata ma'am, for taking out time from her busy schedule and enlightening us with her knowledge and wisdom. I thank all the guest speakers, Dr. Pavan Prashar, Dr. Anuradha Raj, Dr. Anchal Thakur, Dr. Sahil Goyal, Dr. Shafi Badwal, and Dr. Rohan Kapoor for their valuable participation. I thank our respected guests of honor, Dr. S.K. Chopra sir and Dr. S.F. Bhatti sir, for their blessings and guidance. I thank our worthy President of Punjab Ophthalmological Society, Dr. Nilima Sodhi, and Secretary of Ludhiana Ophthalmological Society, Dr. Neeraj, and other eminent eye specialists from the city for gracing this occasion. I thank Principal Nursing College, Mrs. Usha Singh, for her help and support. I thank the guest house in charge, Mrs. Sapna Malviya, GS Office, Maintenance Office, Security and Sanitation Department, and Transport Office, and Mr. Charachand for extending their support. I thank Mr. Avatar Masi for all the audiovisual arrangements, live streaming, and photography. I thank the Student Council and MBBS batch of 2020 for their participation.
A special thank to our MBBS students, Ms. Athira, Mr. Ayush, and Mr. Mohammad Yaqub for being the master of ceremony and for creating excellent invitation videos of this oration. I thank our esteemed faculty members of CMC Ludhiana for gracing this occasion with their presence. I thank the PG residents of our department, BSc Optometry students, interns, MBBS interns, our office staff, Mrs. Naresh Uppal, Mr. Pawan, and Mr. Mandeep for their untiring efforts to make this event a success. I thank our worthy head of the department, Dr. Nitin Batra sir, for his leadership, guidance, motivation, and unmatched enthusiasm. I thank Dr. Rupali Chopra for her valuable contribution, encouragement, and guidance. I thank Dr. Reenu and Dr. Sampson for their contributions. I thank Aromed Pharmaceuticals for all their help and support for this oration. And finally, I thank the media members for the coverage of this event. Now, I would like to request all the dignitaries, CMC administration, our guests, and the Department of Ophthalmology to kindly assemble for a group photograph. And I also request everyone to proceed for refreshments and tea in the lawns outside the MS office, and to kindly rejoin us for the CME in this auditorium after half an hour. That means at 11. Thank you.
Ma'am, we tried on ma'ams, so it was not working, Namrata ma'ams. So 3-4 connectors. USB drive D.
There will be two folders with one pen drive.
Sir, which all?
SS, hard and draft.
Okay, it's full. I have to copy.
Yes, both the folders. Both are like 250.
Yes, मैम है. श्योर मैम. नहीं नहीं हमने वो डाल दिया था मैम. हाँ जी मैम, मैं अभी डिलीट कर देंगी. ये है आपका. आई डिलीट इट मैम. Yes, it's working.
कौन सा कॉपी हुआ अभी?
Sir, SDS.
Begin with loose epithelium over the bulging eye.
जो आज लेक्चर लिया था वो कॉर्निया ट्रांसप्लांटेशन के ऊपर था कि कैसे हम कॉर्निया ट्रांसप्लांट करते हैं कि आगे की जो पुतली होती है जिनकी खराब हो जाती है उसके लिए हम दूसरी पुतली लगाते हैं। और ये कि ज़्यादा से ज़्यादा लोग नेत्रदान करें। जो नया रिसर्च हमने किया है वो किया है सिंथेटिक कॉर्निया के ऊपर, जिसमें कि कॉर्निया सिंथेटिकली बना रहे हैं। हमें 50 से ज़्यादा लोगों के हमें इसका ऑलरेडी हमने कॉर्निया ट्रांसप्लांट कर दिया है और इसके रिजल्ट्स काफ़ी अच्छे हैं। तो जो बायो इंजीनियर्ड कॉर्निया है वही फ्यूचर होगा कॉर्नियल ब्लाइंडनेस के लिए। और बाकी लोगों से अपील करना चाहेंगे कि कॉर्निया का डोनेशन करें, नेत्रदान करें, क्योंकि एक कॉर्निया को स्प्लिट करके हम 3 लोगों को जो है वो रोशनी दे सकते हैं। तो अगर एक कोई व्यक्ति नेत्रदान करता है या अपना कॉर्नियाज डोनेट करता है तो 6 लोगों को रोशनी पहुंचा सकते हैं। क्योंकि अगर कोई पैलेटली ब्लाइंड या दोनों आँखों में भी किसी का अंधापन है और उसको अगर एक ही आँख से दिखना शुरू हो जाए तो वो अपनी दिनचर्या या दिन की जो भी एक्टिविटीज़ है उसको पूरा कर सकते हैं। तो अभी फ़िलहाल जब तक कि ये बायो इंजीनियर्ड कॉर्निया बनने की प्रक्रिया चल रही है, इस दौरान हमें लोगों से ये अपील करनी है कि वो आइज डोनेट करें और कॉर्निया ट्रांसप्लांटेशन की रेवोल्यूशन है उसमें हमारी मदद करें।
आजकल मैम छोटे छोटे बच्चों को 8 साल 7 साल के बच्चों को चश्मे लग रहे हैं मैम, इसका क्या कारण है?
छोटे बच्चों को चश्मे लग रहे हैं क्योंकि आजकल जो पास का काम है वो बहुत ज़्यादा बढ़ गया है। पहले बच्चे बाहर खेला करते थे, लेकिन आजकल वहाँ तक ये कम हो गया है। तो अपने बच्चे भी अपने फ़ोन्स पे या कंप्यूटर्स पे या लैपटॉप पे लगे रहते हैं। तो ये ज़रूरी है बच्चों को बोलना कि वो बाहर जाके खेलें, क्योंकि जितना आप पास का काम करेंगे उतना चश्मा लगने की, जिसे हम मायोपिया कहते हैं, वो एक एपिडेमिक के रूप में आ रहा है। और इसलिए ज़रूरी है बच्चों को बोले कि बाहर ज़्यादा खेलें और लैपटॉप या कंप्यूटर या फ़ोन तभी इस्तेमाल करें जब उसका इस्तेमाल करना चाहिए।
उन्होंने तो जो आई डोनेट करते हैं प्रोसेस की है जी, दवाई डोनेट करते हैं, तो प्रोसेसिंग कैसे होती है? स्टार्टिंग कहाँ से कहाँ पे जाना पड़ेगा डोनेट करने के लिए? कैसे
डोनेट करने के 2 तरीके हैं। या तो आप अगर आप डोनेट करना चाहते हैं तो सबसे इम्पोर्टेंट चीज़ है कि आप अपने रिश्तेदारों को ज़रूर बता दें कि आपकी ऐसी इच्छा है डोनेट करने की, क्योंकि आप वॉलंटरी डोनेशन करेंगे तो आपको एक फॉर्म होता है जो हर आईपैक में उपलब्ध है, वो आप भर के दे सकते हैं। लेकिन अगर आपने वो फॉर्म भर के भी दिया हुआ है आई डोनेशन के लिए, जब मृत्यु हो जाती है तो जो डेड बॉडी होती है वो आपके रिश्तेदारों की प्रॉपर्टी होती है। और अगर भी इस चीज़ के बारे में बोलेंगे कि ये नेत्रदान हमें करना है तभी हो पाएगा। तो अगर आपकी ऐसी इच्छा है तो आप अपने बहुत करीबी रिश्तेदार हैं, बच्चे हैं, उनको ज़रूर बता के रखें कि आपकी ऐसी इच्छा है जो वो पूर्ण करें आपके मरने के बाद।
ਸਾਡੇ ਨਾਲ ਡਾਕਟਰ ਨੀਲਿਮਾ ਸੂਰੀ ਵੀ ਹੈਗੇ ਆ ਜੀ, ਪੰਜਾਬ ਮੁਕਤਿਰ ਸੁਸਾਇਟੀ ਦੇ ਪ੍ਰੈਜ਼ੀਡੈਂਟ ਹੈਗੇ ਆ। ਸਾਰੀ ਐਕਟੀਵਿਟੀਜ਼ ਸਟੇਟ ਦੀ ਦੇਖ ਰੇਖ ਦੇ ਵਿੱਚ ਲਾਈਵ
ਮਾਰਦੀ ਇਹ ਮੋਣਾ ਛੱਡ ਦੇ ਯਾਰ ਇੱਧਰ ਆ ਜਾ। ਚਲੋ ਜਦੋਂ ਸਾਇਲੈਂਟ ਕਰ ਦਵਾਂ ਹੁਣ ਫਿਰ ਵਿੱਚ ਵੱਜ ਜਾਣਾ, ਫਿਰ ਤੁਸੀਂ ਕਹਿੰਦਾ ਵਿੱਚ ਵੱਜ ਗਿਆ।
ਸਾਡੇ ਲਈ ਅੱਜ ਇਹ ਬਹੁਤ ਆਨਰ ਦੀ ਗੱਲ ਹੈ ਕਿ ਸਾਡੇ ਪੰਜਾਬ 'ਚ ਇੰਨੇ ਐਮੀਨੈਂਟ ਸਪੀਕਰਸ ਆਏ ਨੇ ਤੇ CMC ਨੇ ਡਾਕਟਰ ਨਿਤਿਨ ਬਤਰਾ ਨੇ ਇਹ ਆਰਗੇਨਾਈਜ਼ ਕੀਤਾ ਕਿ ਜਿਹੜਾ ਓਰੇਸ਼ਨ ਅਵਾਰਡ ਹੈ ਤੇ ਓਰੇਸ਼ਨ ਦਿੱਤੀ ਜਾਏ ਡਾਕਟਰ ਨਮਰਤਾ ਸ਼ਰਮਾ ਨੂੰ। ਸ਼ੀ ਇਜ਼ ਅ ਰਿਨਾਊਂਡ ਫਿਗਰ ਫਰੋਮ ਆਲ ਓਵਰ ਦ ਵਰਲਡ। ਔਰ ਜਿਹੜਾ ਅੱਜ ਦਾ ਟੌਪਿਕ ਰਿਹਾ ਉਹ ਸਾਡੇ ਪੰਜਾਬੀਆਂ ਲਈ ਵੀ ਸਾਰਿਆਂ ਨੂੰ ਸਮਝਾਉਣ ਦੀ ਗੱਲ ਹੈ ਕਿ ਬੇਸਿਕਲੀ ਤੁਸੀਂ ਆਰਗਨ ਡੋਨੇਟ ਕਰਨਾ ਹੁੰਦਾ। ਆਰਗਨ ਡੋਨੇਟ ਹੁੰਦਾ ਜਿਵੇਂ ਅਸੀਂ ਕੋਰਨੀਆ, ਅੱਖਾਂ ਲਈ ਅਸੀਂ ਕੋਰਨੀਆ ਡੋਨੇਸ਼ਨ ਕਰਦੇ ਹਾਂ। ਇਹ ਇੱਕ ਐਸੀ ਡੋਨੇਸ਼ਨ ਹੈ ਜਿਹੜੀ ਬੰਦੇ ਇਨਸਾਨ ਦੀ ਮ੍ਰਿਤਿੂ ਤੋਂ ਬਾਅਦ ਲੈਣੀ ਹੁੰਦੀ ਔਰ ਉਹਦੇ ਨਾਲ ਕੋਈ ਬੋਡੀ ਦੀ ਡਿਸਫਿਗਰਮੈਂਟ ਨਹੀਂ ਹੁੰਦੀ ਹੈ। ਉਹ ਅਸੀਂ ਸਾਰਾ ਪ੍ਰੋਸੀਜਰ ਡੈਡ ਬੋਡੀ ਦਾ ਕਰਕੇ ਦਿੰਦੇ ਹਾਂ ਇਸ ਤਰ੍ਹਾਂ ਕਿ ਉਹਦੀ ਡਿਸਫਿਗਰਮੈਂਟ ਨਾ ਹੋਵੇ। ਕਿਸੇ ਨੂੰ ਇਹ ਚੀਜ਼ ਬਾਰੇ ਸੋਚਣਾ ਨਹੀਂ ਚਾਹੀਦਾ, ਕਿਉਂਕਿ ਜਦੋਂ ਡੈਡ ਬੋਡੀ ਹੈ ਅਸੀਂ ਤਾਂ ਉਹਦਾ ਸੰਸਕਾਰ ਹੀ ਕਰਨਾ ਅਤੇ ਵਾਈ ਨੋਟ ਕਿਸੇ ਦੀ ਜ਼ਿੰਦਗੀ ਤਾਂ ਦਈਏ ਨਾ। ਜੇ ਅਸੀਂ ਕਿਸੇ ਨੂੰ ਅੱਖਾਂ ਦਾਨ ਦਿੰਦੇ ਹਾਂ ਇਹ ਸਭ ਤੋਂ ਵੱਡਾ ਦਾਨ। ਸੋ ਸਾਨੂੰ ਪੰਜਾਬੀਆਂ ਨੂੰ ਇੱਕੋ ਹੀ ਚੀਜ਼ ਦਾ ਧਿਆਨ ਰੱਖਣਾ ਕਿ ਪਲੀਜ਼ ਅੱਖ ਦਾਨ ਕਰੋ, ਕਿਉਂਕਿ ਜਦ ਤੱਕ ਅਸੀਂ ਇਹ ਇੰਜੀਨੀਅਰਡ ਕੋਰਨੀਆਜ਼ ਬਣਾਵਾਂਗੇ ਇਟ ਵਿਲ ਟੇਕ ਟਾਈਮ। ਤਦ ਤੱਕ ਤਾਂ ਸਾਡੇ ਬਹੁਤ ਮੁਲਕ 'ਚ ਲੋੜ ਹੈ। ਬਹੁਤ ਜੰਮਦੇ ਬੱਚੇ ਅੱਜ ਕੱਲ੍ਹ ਬਲਾਈਂਡ ਹੈ, ਵੱਡਿਆਂ ਨੂੰ ਤਾਂ ਲੋੜ ਹੈ ਹੀ ਹੈ, ਪਰ ਜੰਮਦੇ ਬੱਚਿਆਂ ਨੂੰ ਵੀ ਤਾਂ ਜ਼ਿੰਦਗੀ ਦੇਣੀ ਹੈ। ਸੋ ਇੱਕੋ ਹੀ ਬਿਹਤਰ ਸਾਡਾ ਕੰਮ ਹੈ ਕਿ ਪਲੀਜ਼ ਅੱਖਾਂ ਦਾ ਦਾਨ ਕਰੋ ਕਿ ਜਿਹੜਾ ਮ੍ਰਿਤਿੂ ਤੋਂ ਬਾਅਦ। ਥੈਂਕ ਯੂ ਸੋ ਮਚ।
मैं कभी आगे 100 ग्राम तक आ हाथ पैर इधर आ जाएगा और यहाँ पे चेयरपर्सन के लिए कुर्सी लगी हाँ कितने जगह इधर भी चलते तू किधर घूम रहे हैं कैमरा चढ़ के ऑफिस के सामने भज के जा कैमरा इन्हें नहीं है तेरे पास 5 मिनट है इधर भी जा भज के जा बिल्कुल नहीं है ये कैमरा लेके जा
छोटा टेबल होएगा उधर
वहाँ 5 मिनट की ना
छोटा टेबल
उसके बाद नाश्ता करना है उसके बाद नाश्ता करके वापस आना
to his name. And one such is the Young Achievers Award given by the North Zone Ophthalmological Society.
the prestigious Pradeep Swaroop Award by the All India Ophthalmological Society. He has 50 publications and has led more than 140 presentations in several international and national regional conferences and journals. He was also awarded the Best Paper Award at the Biennial Conference of Himachal Pradesh Ophthalmological Society and is an active member of the editorial board and a reviewer for numerous notable international and national journals. Sir, we are highly humbled and honored with your presence today. Before leaving the mic, I humbly submit to all the speakers of this session to kindly limit themselves to the timeline of 20 minutes, inclusive of the questionnaire round.
Good morning, everyone. At the outset, I would like to thank the organizers, especially Dr. Nitin Batra and my respected seniors, Dr. Rupali and Dr. Guruvinder, for giving me an opportunity to make this presentation. And I must acknowledge that after the spell-binding oration by Dr. Namrata Sharma, this work is mostly inspired by her work and work from her colleagues, Dr. Titial and Dr. Vajpayee. So my topic is component corneal surgery, relevance in Indian scenario. There's no financial interest. So corneal transplantation, as we all know, it is the most successful of all organ transplants because cornea is unique, avascular and immune privileged structures, unlike other parts of the body. The concept was first suggested by Erasmus Darwin, who was grandfather of Charles Darwin in his book Zoomania. And in slides are not running. It's not moving. Should I go like down? Slideshow में जाके slides बंद करके दोबारा स्टार्ट करें। सर की यहाँ पे एक सेकंड बहुत ज़्यादा चीज़ों को उस पे नहीं आ रहा है ठीक है sorry about that इसको गायब कर दो कैसे जाएगा So the first corneal transplant was done in 1905 by Dr. Edward Zerm. And as Dr. Namrata told in the morning, for nearly a century, the only available treatment for corneal pathology was full thickness penetrating keratoplasty. But over the last 2.5 decades, there has been paradigm shift towards lamellar corneal surgery to minimize surgical trauma. And with the advent of specialized lamellar keratoplasty techniques by the work of Sir Jarrett Malles and Frank Price and Mark Terry from USA, now the emphasis on selective excision of the diseased corneal tissue and replacement by the healthy donor corneal tissue only of the relevant part. The term component corneal surgery was first conceptualized by Shimura in Journal of Cornea in 2004, and now we know that various components can be individually transplanted, like epithelial stem cells, Bowman's layer, stroma, and Descemet membranes plus endothelium. Advantages, there is decreased risk of graft rejection and avoidance of complications of open sky procedures like expulsive choroidal hemorrhage. With the endothelial grafts, there are it's sutureless, so there are no suture-related complications, and also it opens our door to utilize one cornea for multiple recipients, which can have immense value in developing countries like ours, where there is always a paucity of good quality donor tissues. So I'm sharing a couple of our experiences. One cornea for 3 patients. Patient 1 was a 40-year-old male, diminution of vision for last 6 months, history of penetrating keratoplasty 1 year back elsewhere. Initially had good vision, but then there was gradual deterioration, and on presentation vision was 6/36. So here these are the slit lamp pictures with marked graft edema and the Scheinfeld image. So the plan was to do a DSEC on this. So in DSEC, the diseased corneal endothelial layer is removed, and while leaving the anterior layers intact, and a healthy graft is fashioned, prepared, and inserted into the eye through a small incision in the periphery. And after insertion, the graft is unfolded, and it is held in place with an air bubble, and the sutures are not required. This is how it would look in the post-operative period. So this patient, 1 day after a DSEC, had the graft is in place, some air bubble in the anterior chamber, and after 3 weeks, this is the appearance of that eye. And on Scheinfeld image, you can see there is gradual detergence of the edema and improvement of the visual acuity. So from 6/36, at 3 months, he has best corrected vision of 6/9. The patient 2, at the same time, I was managing a 45-year-old male who was referred with complaints of diminution of vision and severe pain in his right eye for last 2 months, had been diagnosed as corneal ulcer and had received treatment from multiple ophthalmologists. No relevant systemic history, lab work was negative. And this is the appearance. Best corrected vision was 6/60. On slit lamp, there was a crescent-shaped ulcer with central perforation measuring 3.5 mm to 2.5 mm with iris prolapse. So case of a PUK on high magnification. So for this, we used the rim of the same cornea from which we have done the endothelial keratoplasty earlier, and it was trimmed to appropriate sized graft, and it was sutured to the host bed after freshening of the margins and doing a conjunctival resection. The graft initially, the patient initially had a lot of anterior chamber reaction, but graft gradually gets taken up, and with improvement in signs and improvement in visual acuity, and this is the post-operative at 3 months. The third patient, at the same time we were managing, was a 50-year-old female who was referred for the management of non-healing fungal corneal ulcer in her left eye. So she had fungal keratitis treated with intensive topical and systemic antifungal with regular debridement as per routine. The infiltrate resolved, but there was marked thinning of the stroma leading to descemetocele formation and impending perforation. You can see these stria and marked thinning in a couple of areas where there was eventual perforation was expected. So considering the risk of eventual perforation, she underwent a patch graft to replace the anterior stromal tissue defect, and for this we used the anterior lamella of the same cornea, and appropriate size patch graft was fashioned from this anterior lamella, and it was sutured to the host bed. And this is post-operative 3 weeks. Uncorrected vision, she improved to 6/18. Eventually, sutures were taken out. Through this, a significant portion of the pupil was not involved, so she could continue seeing through that. And eventually, she developed a cataract, and I did a cataract phaco after couple of years, and she improved to 6/9, best corrected. So here, we were able to use 3 components of 1 cornea in 3 patients, which in a different scenario would have required 3 cornea. And this was not one-off incident. As corneal surgeon, we try to use whatever components we have of the cornea available as judiciously as possible. And this is another case of ciliary staphyloma after a complicated cataract surgery in the past somewhere. else. And we did use the rim to do a tectonic patch graft. And this is a post-operative experience. Patient was sent back to his referring ophthalmologist for further management. Another case, PUK with perforation. So initially I tried the glue, but sometimes it doesn't stick. So eventually I had to do a patch graft with the scleral tissue I had with me. And the central part was used for a scarred PBK cornea. So we were used to used for more than one patient. Another patient, 68-year-old female with the perforation in the periphery. I put a scleral patch graft, but some way it wouldn't seal well, so I used the Tenon's patch from the same. So you can augment, like use a couple of techniques if one is not working. Gradually the graft, tissue gets integrated with the host tissue, and then you remove the sutures and central part is clear. She developed a cataract, did a cataract surgery later on, and improved to 6/12. Now, why is it important? Because the eye bank scenario in India is there is always a marked shortage of good quality corneal tissue, and some of the data from NPCB against a target of 55,000, the number of donated eyes was 17,000, and keratoplasty was done in around 12,000 cases. And as ma'am said, that we need like 2 lakh and corneas eventually. So there is the demand or the need for donor tissue is many times the current procurement, and this is an article in Times of India where I think this statement by Dr. Namrata Sharma only, that 11 lakh corneal blind patients in India are awaiting transplant, and there being a dearth of eye donation in India, the burden of blindness is still piling up, and corneal blindness needs to be advocated as the biggest good one can do to the world once he or she leaves the world. And in this data presented, there are some significant issues or concerns, that 60% of the total collection is done by only top 10 eye banks, and top 18 eye banks contribute to 18%, and there are 702 of the rest of the eye banks, they contribute only 20%, means they are either not working to their efficiency or they are not functional. So that is one area which needs to be improved, and especially in our part of world, in Punjab and northern states, the eye bank, hopefully, this is one area which has been neglected, and I hope it sees improvement in future. So in such a scenario, where there is huge gap between demand and supply, customized component corneal transplantation appears an exciting proposition, as it seems to have the potential to reduce the demand by 2 to 3-fold magnitude, because it can use one tissue for multiple patients. The concept in India was first given by Dr. Vajpayee and in 2007, where they used anterior lamellar disc for macular dystrophy, posterior for PBK, and rim for corneal stem cell transplantation. And Dr. Namrata Sharma and her group published another paper, very important, where they used 12 cornea for 24 patients, and with very good visual outcome in all the cases. So by using this technique, the anterior lamellar button can be used for anterior pathologies and posterior for endothelial keratoplasty, and peripheral donor tissue can be carefully salvaged, can be used as a patch graft and like a banana graft, like I showed in one of the patients, for limbal stem cell transplantation, and also as a covering for glaucoma tube shunts by our glaucoma colleagues. So another benefit is there is a reduction in the cost of procedure, because one cornea tissue from the private eye banks, it has significant cost. So we definitely cuts down on the cost, but here the role of eye banks is very important, because we need to get pre-cut tissue to avoid wastage and have it ready. So, so various steps can be advocated to improve the utilization. A policy of multiple use of single donor tissue can be implemented by organizing a suitable pool or a data set of the patients who are waiting for keratoplasty or another corneal procedure in a particular area, and the data should be available with the cornea surgeons. And also there is a need for awareness among the eye care professionals regarding early referral of the patients requiring keratoplasty, especially endothelial keratoplasty, and in cases with impending perforation. So this is one area which I'd like to highlight every time, that primary referral is the key. It is a known fact that with time, stromal scarring develops in patients with bullous keratopathy, making them unsuitable for posterior lamellar keratoplasty, thus precluding the best possible visual outcome. And also, a corneal ulcer which is worsening or not responding to treatment, or patient with impending perforation or desmetocele, is no longer a medical case, and it has to be dealt with surgically. So that patient must be referred to a facility for PKP without delay. To conclude, rapid progress is being made in the field of anterior and posterior lamellar keratoplasty, and the trend may continue to decrease the indications for PKP in future. And hopefully the use of single donor tissue in more than one patient may become a standard surgical practice, as it offers tremendous potential in our collective fight against corneal blindness. So we published our series in one of the peer-reviewed journals as corneal component surgery, expanding the indications. And thank you very much for your attention and for the opportunity.
Thank you, sir, for your exceptional presentation. I request you to stay on the stage, and would like to call upon Dr. Nitin Batra, sir, to present a token of appreciation.
Thank you for your wonderful presentation. I am from the old generation. Kindly be seated. That's all, makeup. Well, so there was a time when we had wonderful 3 professors in our department, and they were all comprehensive ophthalmologists. Dr. Chatterjee, Dr. Daniel, and Dr. Chopra. And we were students, we learned a lot of things from them. So one of the things was keratoplasty, which we learned from them only. I didn't have any fellowship, but after they became little senior, so they left many things on us, on juniors, and we used to do all sorts of surgeries, including keratoplasty. And that was the era when these intraocular lenses were just started in India. Dr. Daljit Singh, he started in late 70s. So at that time, many things were not available. No viscoelastics or very poor quality viscoelastics. Am I right, madam? Yeah. So things were not very good. Instruments were not of that good quality. And the type of lenses he was using, they were iris clip lenses. And we had a lot of corneal decompensation. And some would land up in our clinic. And we used to do. But the maximum work was being done by Dr. D.C. Bansal and Dr. Sodhi. She's not here, Neelima. So they were doing a lot of work. I think in India, one of the biggest number which was being done, that was in Patiala. And Dr. Neelima Sodhi was with Dr. D.C. Bansal, and they did a lot of work. And it is so good to hear that now just one cornea can be used probably for 3 patients. So endothelial keratoplasty can be done, and anterior lamellar keratoplasty can be done, and wherever peripheral cornea or sclera is required. So it is a very big achievement. It's a step forward. So as ma'am said in her oration also, that one patient, if donates eyes, so 2 eyes, sometimes 6 people can recover with one person's donation. So it is a wonderful thing, and I congratulate all corneal surgeons for doing wonderful job. If anybody has any question, there is time now, can ask the question. If no question, we'll proceed further. Okay.
Now I would like to call upon our next distinguished speaker, Dr. Anchal Thakur ma'am, Assistant Professor at the Advanced Eye Center at PGI Chandigarh. Ma'am has completed her MS Ophthalmology from Jawaharlal Nehru Medical College, AMU Aligarh, and has a fellowship in the International Council of Ophthalmology from UK. She has completed a variety of projects approved by the CSIR and an ongoing project approved by the ICMR. In the year of 2019, she won an award in the ophthalmic photography competition in the IIRSI conference. And in the following year, she was again awarded the grand prize by the IIRSI. She has over 40 publications in index journals and has co-authored a few chapters. She has presented papers in national and international conferences. We are delighted to host you, ma'am.
Yeah, thank you. At the outset, I would like to thank Dr. Batra for this kind invitation and for a wonderful CME. So I would start my talk about pediatric keratoplasty. The most important thing in a patient of pediatric keratoplasty is making a diagnosis. Nowadays, we have tools like anterior segment OCT as well as ultrasound biomicroscopy, with which we can see whether there is cataract behind the opacified cornea, so that we can make a correct diagnosis before we jump into keratoplasty. The second most important thing is assessing visual potential. We have VEP, that is visually evoked potential. We must do it in children in which we are not sure that whether they are perceiving light and which eye to operate, because normally a 3-month-old or a 6-month-old child will not allow you to see that which eye you should operate. So in decision making, this is very helpful tool. The second is assessing family support and willingness and frequent follow-ups. This is, I think, the most important thing, because we have to counsel the parents first, and the family has to be very supportive if we have to take the child for a keratoplasty. Assessing the presence of comorbidities, the most important of which is glaucoma, which is again the most common complication after doing a keratoplasty. So if we go and see the surgical trends in pediatric corneal transplantation, this was a 13-year-old review with a database of 2,060 cases, in which again penetrating keratoplasty was the most commonly performed surgeries, but the trend is changing now, as ma'am said, and we are going on for endothelial as well as DALCs. In my clinical experience, I see most of the patients are with congenital glaucoma. The second is Peters anomaly, congenital hereditary endothelial dystrophies, and perforated corneal ulcers. So what is the timing for surgery? Actually, there is technical difficulty in PK in children. I'll show you some videos later. Due to decreased scleral rigidity and increased elasticity, there's difficulty in suturing, and there are very high rates of graft rejection, need of multiple EUAs, and risk of glaucoma and amblyopia. On the other hand, an early corneal transplant can lead to a good visual outcome and decreased effects of amblyopia. So traditionally in books we read that what is the recommendation, when should a child undergo a keratoplasty? A child with bilateral congenital corneal opacities should undergo corneal transplantation within the first 3 months of life to minimize amblyopia. So what are the surgical indications? First is IV mannitol. This is actually a must for all children till 12 years of age, because there is a very high risk of suprachoroidal hemorrhage. So the dose is like 1 gram per kg. We have to instruct the anesthetist before we take up the child that once the child is induced, IV mannitol has to be given. Use of a Flaringa ring. Because the pediatric sclera is very less rigid, there is again risk of suprachoroidal, as I told. So we have to use a Flaringa ring at the limbus, near the limbus. I'll just show you the video. And again, cautious suturing. And we have to be prepared for a cataract surgery with a vitrectomy cutter. Some surgeons, they advocate the use of 2 milligram intracameral DEXA along the orbital floor so that a sustained release of steroids can be there in the post-op period. What is the timing for EUA as well as timing for suture removal? First EUA, I would say, should be done at first week. And for infants, we should try and remove all the sutures by at least 3 to 4 months. Or whenever you see vascularization, whenever we perform an EUA, we have to see if there is vascularization and if the graft host junction is healed, we should remove the sutures. because sutures are a source of graft rejection later. And if the child is more than 1 year of age, the formula is like we should add 1.5 to the age, like 1.5 to 3. If the patient is 3 years old, it will be 4 to 5 months for suture removal. So this was a child, he was PL positive with nystagmus, and the surgery performed was optical penetrating keratoplasty along with cataract extraction as well as anterior vitrectomy. This patient had already undergone a trabeculectomy and had a glaucomatous cupping behind 0.8 cup. He was fixing and following light, but he had nystagmus, so he underwent a penetrating keratoplasty. The idea is we should use tissue with a healthy endothelium. It should be more than 3000, but we can get away with 2800 endothelial count. But to our surprise, the next post-op day, we had serous choroidals on ultrasound. We had to start the patient on oral steroids and topical steroids anyways, and so we did an EUA after 3 days to look for suture leak. This is again important because the child will not show. We have to take the child for an EUA after maybe 3 or 4 days. But because the child had serous choroidals, we took him up for the 4th day. There was no leak, so we kept him on oral and topical steroids, and then the child improved. The vision was like counting finger 1 meter, but it was enough for him to, enough ambulatory vision was there. But later, the patient developed endothelial dysfunction because of raised IOP. Again, a patient of primary congenital glaucoma, there are a lot of issues. The most common is that trabecular meshwork collapse is there due to loss of anterior and posterior support. And the mechanical effects of tissue compression by the sutures leads to high IOP. And the child will not tell, he'll not complain of any pain, and then he'll come with a slow rejection because of the raised IOP. Actually, penetrating keratoplasty in a child is like a ticking time bomb. So we have to do frequent EUAs and keep counseling the mothers to look that whether there is corneal edema or there is suture infiltrate or anything, because the child never tells. So this was again a boophthalamus patient with a 14 millimeter of diameter of the cornea. He was also a bilateral congenital glaucoma patient. So we used Fleringa ring. The ideal place to suture is actually 3 to 4 millimeter beyond the limbus. But since this was the largest size available, so we used this and we tried to suture with a vicryl. After using the side port entry, we have to inject the viscoelastic so that we push all the intraocular contents behind. Then the recipient trephination is done using a standard 7.58 mm. So we use the 8 mm donor tissue and then we refine the 7.5 mm recipient tissue using the standard steps of keratoplasty. I think I can't forward here. So after 4 months, a repeat EUA was done. The graft was doing fine, but the child was lost to follow-up and he came after 2-3 months. The parents were not putting drops, and again the child ended up in graft rejection. This is a third case. This was also a bilateral blind child, underwent multiple surgeries. And now we can see that there was a 360-degree pannus. So the first step is to remove and dissect the pannus. Again, we can see that the limbus is ill-defined and he has already undergone 2-3 surgeries, first trab, then tube, and then phacoaspiration. So both the corneas, they look the same. He was bilaterally blind, PL positive, so we took him up for keratoplasty. After making the center with the Sinskey hook, we started doing the recipient trephination. As compared to the other 2 patients, the cornea was very thick. So we have to take care that there should be no expulsive hemorrhage, because we don't know actually whether vitreous is going to come or the aqueous is going to come, because the child has undergone a phacoaspiration and he's aphakic. After inflating the anterior chamber with viscoelastic, careful trephination is done using right and left Castor-Viju scissors. And then again an 8 millimeter donor trephination is done and sutured using 10-0 nylon sutures. So the child was doing fine, and we did an EUA at 1 week and then at 2 months, and At 3 months, all of the sutures were removed. And the vision gradually improved to 6/18. The point here is that we started the patient on oral steroids in the immediate post-op period, and we prepared him for oral immunosuppression. So oral immunosuppression can be in the form of cyclosporin or mycophenolate meftil. But this child was started on oral cyclosporin after taking the pediatric rheumatology consult. And even after 1.5 years after suture removal and after keratoplasty, he's doing well, he's walking around. And we have to carefully see about the LFTs and RFTs. Constantly we have to monitor the serum cyclosporin levels. It has to be like 120 to 150 nanogram per ml. Again, the choice of immunosuppression depends on the pediatric rheumatologist as well as the surgeon. So we chose cyclosporin. Cyclosporin and many other drugs, they have equal results. I'll show you in the next slide. This was an again child of congenital ectropia on UV. Both eyes underwent CTT, trab tube as well as DLCP. Underwent keratoplasty, and she's also doing fine. We did a second surgery in the form of membranectomy, and she's like 3/60 with the phakic glasses. These were two children with perforated corneas. They came with corneal infection, and then they had iris prolapse. So they're also doing fine with a bigger graft. Again, the lower picture is of a child who has a systemic disease called pyoderma gangrenosum, and she's already on oral immunosuppression in the form of oral cyclosporin. So she's doing fine. It's like a 3-year follow-up has been there, and the graft is clear. She's moving about with 6/18 vision. Congenital hereditary endothelial dystrophy, we have this child. He has nystagmus, but he was like 9-year-old. So a standard penetrating keratoplasty was performed, and he's doing fine. This was a 1-year-old girl operated in November 2022 for a condition called corneal keloid. Corneal keloid is a very rare entity which has been described in literature, but I have not seen many kids. These are like second child. And there were IOP fluctuations later in the post-op period, but this child is also doing fine. She's on topical immunosuppression, but we didn't start him on oral immunosuppression since the graft was a little smaller and the sutures were not reaching the limbus. So this child is also doing fine. This was a child of a Peters anomaly. This is actually Peters type 2. As you can see in the UBM picture, there is a descemetic defect, and the iris is adhered to the back of the cornea. And you can see some clefts inside the cornea. These are fluid clefts. This is like Peters type 2. So again, a penetrating keratoplasty was performed for this child, and again the standard steps of surgery were done, and care was taken to give IV mannitol when we were making the side port, because at that time we want the pressures to be lowered, because we want to prevent suprachoroidal hemorrhage. Again, with the child, we are always at a high risk of suprachoroidal hemorrhage. To our surprise, there was intumescent cataract also, which you could make out faintly on the UBM picture. So cataract surgery was performed along with this. Posterior capsule was kept intact, and the second setting, if we feel, then we did a membranectomy, and the child was mobile then. This child was kept on mycophenolate. This was another single-eyed child again, underwent RD surgery for posterior uveitis long back, and she was referred to us for keratoplasty. Although the keratoplasty went well, but the child later had re-RD again, and we can see the retina and the oil globule in the AC with a clear graft. So outcomes depend on the age at which the keratoplasty was performed, the indications for which the surgery was performed, as well as the absence or presence of glaucoma. So these are the literature review about the major studies done in pediatric keratoplasty. The major one is from, again, AIMS only, and it had like 168 eyes. Again, the outcome depends on the indications. If we include patients with keratoconus, if we include patients with perforated corneas, then the outcome is better. If we exclude patients of glaucoma or Peters anomaly, then the outcome will be better. So overall, we cannot comment about the graft survival rate if we look at this table. But the graft survival is like 80% if we include all the patients of non-traumatic and keratoconus patients, obviously. The poor graft survival could be related to those younger than 5 years. Again, the graft rejection rates are higher if the child is younger. And with glaucoma, the graft survival decreases back to 50%. In Peters anomaly, I would say that there is a high chance of glaucoma in the later post-operative period. So the overall long-term probability of maintaining a clear graft after penetrating keratoplasty for Peters anomaly is 35%, with subsequent grafts rarely surviving. So this was a review in which they said that congenital glaucoma was combined with cornealoplasty in 77% patients, and corneal transplant survival was only 50% with those having glaucoma. If we we'll see the complication rate. The most common complication is again graft infection. Again, in India, with an epithelial defect, we know that fungal spores are everywhere. So fungal infections are very high risk for these grafts, and pediatric patients, they don't tell us about pain, and these symptoms are missed. The second thing is graft rejection. They're like actually PK is like a ticking time bomb. So we have to keep following the patient, and we have to, throughout life, we have to tell the parents that till the child shows on slit lamp, he has to undergo every 3 months examination under anesthesia to look for IOP, to look for corneal clarity. Again, coming to immunosuppression, there is a big debate when to start oral or topical immunosuppression. For my patients, I always start topical immunosuppression in the form of tacrolimus for all high risk, because pediatric keratoplasty is anyways a high risk keratoplasty. So we'd have to start the patient on topical immunosuppression. So tacrolimus is far more potent than cyclosporin. So tacrolimus topical is almost started in every child undergoing a penetrating keratoplasty. But oral immunosuppression, we are still not sure which patients to start. So the child which I showed you with the big pannus and bilateral glaucoma child, so we started him on oral cyclosporin, and he's still doing fine with maintaining serum cyclosporin levels of the appropriate levels of 120 nanogram per ml, and we don't know when to stop. All the studies have shown that oral cyclosporin and oral immunosuppression can be stopped after we remove the sutures. That is around 6 months. They have stopped oral immunosuppression because there are a lot of side effects of all these drugs. The patients have to be monitored with LFTs, RFTs, and hemograms so that they don't develop any systemic tumors as Hodgkin's, and there are a lot of many side effects. So this was the only study in which they have given 11 children with high risk grafts were given oral cyclosporin along with oral steroids, and the survival rate was significant in patients who received oral cyclosporin than who received oral steroids. So the key points are that sutures must be removed as early as possible in all the children undergoing penetrating keratoplasty to prevent graft rejection. Even when a child presents late with bilateral and dense corneal opacification, surgical treatment should not be withheld. We think that the patient has now amblyopia, how much will he benefit? But even counting finger 3 meters is a good ambulatory vision for a blind child. And severe visual impairment has a profound effect on global development in an infant and toddler. So even if it fails after 1 year, the global development should justify the intervention. Visual function is again more important than central visual acuity. So I would say like all patients are high risk keratoplasty, especially when we know about the pediatric age group, and threshold of starting oral immunosuppression is still not clear. Thank you.
Thank you, ma'am, for your remarkable presentation. I request you to stay on the stage, ma'am. I would like to call upon Dr. Nitin Batra, sir, to present a token of appreciation.
Very nice presentation, Dr. Anchal. I, being a pediatric ophthalmologist, I also believe that in pediatric age group patients, it is very important to do the treatment as early as possible and do not deny treatment to any child, because the number of blind years in case of children are much more than what they are in adults. And once they do not get the treatment during the childhood time, then in adult it is just cosmetic. So in this part of the country, we have various corneal opacities because of traumas, especially during this season when there is the Sera and Diwali, so those things. And throughout the year, we have the traumas. And you rightly said that the traumatic corneal opacities have a better prognosis. So in this hour, at least in CMC, we don't see too much of Peters anomalies and all those things, but the corneal traumas and resulting opacities are very common. So each and every child should be given an opportunity. A proper counseling of the parent is very important, and more and more pediatric keratoplasty corneal surgeons is the need of the hour. Thank you.
Thank you, Dr. Anchal Thakur, for sharing your experience with us. I just want to ask one question. Have you ever seen choroidal hemorrhage in your cases? How frequently it occurs? Very, very sad. Yeah. I wish all the ophthalmic surgeons may never see such a complication. It is very disgusting, and it demotivates you. Thank you. Sit down. I have also seen only twice this complication in my life. Both the time very senior people were operating. Once it was Dr. Daljit Singh doing intraocular lens, and the whole thing just came out. I was watching that now the vitreous has come, retina, everything out. This first time which happened, it was with Dr. Chopra sir. So he was operating again on a cataract surgery, and everything came out. Almost for 1 or 2 days I didn't have food. I was so disappointed looking at those complications. And thank you for sharing this vast experience which you have at such a young age. Thank you.
Thank you, sir. Now I would like to call upon our esteemed concluding speaker of this session, that is Dr. Anuradha Raj. She is the additional professor and the head of the Department of Ophthalmology, also the Associate Dean of Research at All India Institute of Medical Sciences, Bhatinda, Punjab. Having done her MS Ophthalmology from Government Medical College, Amritsar, Punjab, she has a total of 81 indexed publications in national as well as international journals. She has authored 2 books and penned several chapters in numerous books of repute, and has also adjudicated a variety of international journals alongside being a recipient of diverse accolades. She will be sharing her tips for therapeutic penetrating keratoplasty. We are deeply humbled to host you, ma'am.
First of all, I would like to thank Dr. Nitin sir for giving me this opportunity, and Rupali ma'am for giving me such a kind hospitality. Thank you, ma'am. So the topic of my talk is practice pearls for therapeutic penetrating keratoplasty. So therapeutic means to treat something. So that is for mainly major of the things are non-healing corneal ulcers, keratitis, and we need to save these eyes structurally as well as functionally. Various indications are large ulcer which progress towards the limbus or involves sclera, or corneal melting or ectasias due to some kind of chemical burns, or perforated corneal ulcers if they are more than 3 mm in size, and larger corneal abscesses which are involving the whole of the cornea, all the layers of the cornea. So various steps for these procedures are, first of all, preoperative preparation is very important. Anesthesia part, surgical preparation is very important in these cases, trephination of donor and recipient cornea, suturing, and then postoperative treatment, which actually conclude the surgery. So the goals of TPK are elimination of the infective load, because the whole cornea is having the organisms and that is already molten or sloughed out. We have to remove that, and then we have to send this piece for histopathological examination to find out what is the organism and how it will go, whether it is recurring or it is not recurring, to maintain the structural integrity, and at last visual rehabilitation if we can maintain the anatomical integrity, and if the graft is not actually surviving, we can do optical penetrating keratoplasty. So preoperative preparations, we have to see the adnexal evaluation is very much important. Visual acuity, what is if PL denied is patient is there, then we should not go for that. B scan to rule out vitreous hemorrhage or any endophthalmitis, choroidal detachment, retinal detachment, lens status, whether patient is pseudophakic, aphakic, what is the IOP of the patient. Then evaluation of the ulcer depth. What is the depth? We can see on anterior segment OCT. Extent of the infiltrates can be seen to decide how much cornea we should be removing. Imaging of the perforated ulcer should be there with us for all the records purpose. Limbal involvement, if it is there, because it helps in prognostication of the cases. If it is involving the sclera, it is somewhere we know that it may have bad prognosis or it may have recurrence. Associated endophthalmitis or glaucoma may need various surgeries on the table or maybe afterwards. So retrocorneal membranes were very important because we need to find out whether they are peripheral anterior synechia or their pupillary involvement is there. We can see very much on the anterior segment OCT, if iris is adherent to that, we can snip off the cornea layer by layer so that we will not damage iris at all. Then anterior chamber distortion can be seen on anterior segment OCT, status of the IOL or maybe crystalline lens, what is the position and whether we are encountering the cataractous lens or not, or we are encountering the lens just behind the cornea, we need to see that before. Fundus examination and systemic or topical antibacterials, they are very much important. Preoperative assessment can be done as I have already told, UBM, anterior segment OCT and B-scan, they form a very integral part of the preoperative examination. B-scan, because in these cases mostly fundus is not visible, so B-scan is required to find out whether there is endophthalmitis or what is the status of retina, retinal detachment is there, endophthalmitis is there, or choroidal detachments are there. So if choroidal detachments are there, then we have to, maybe we need to drain the choroids also. So fasting sugar is very much important because mostly these patients are diabetic and they are under very bad control. Renal function should be tested before because we need to give them mannitol maybe for once or twice or maybe more than that to control IOP. Topical pilocarpine should be put in the anterior chamber to push the posterior iris lens diaphragm posteriorly so that we will not encounter the lens very much near the vicinity of our trephinations. So donor tissue quality, if good quality cornea is there, that is very good because healthy endothelium, it has the chances of good clarity and inflammation because these cases are prone to inflammation post-operative also. So that will be good if we are getting good cornea. For that we should preferably use good quality cornea. But if not available, then non-optical cornea like that glycerol preserved can also be used, which are devoid of live cells because chances of rejection are less, but they can maintain the anatomical integrity and steroids are also very less required. So tissue suitability, any kind of tissue with good epithelium or maybe some kind of exposure, sloughing or stroma, maybe edema or arcus is there, descemetes if it is having stria or folds, or endothelium if it is having polymegathism, it is good, it's okay. And ECD, if any kind of ECD, if it is 1500 over even, then even we can use that. Various kind of presentation can be with us, such kind of like first photograph is showing this descemetocele with all the anterior chamber is collapsed, with other is also having descemetocele, third is having that crystalline lens which is popping out of the perforation, third is involving the limbus, fourth is having everything is out and the crystalline lens was there in the conjunctival sac and this vitreous is herniating through this perforation. So in these cases, IV mannitol we have to give to the patient in preoperative management 15 to 20%, IV 1 to 2 gram to reduce the vitreous volume and maximum effect is achieved in 30 minutes. Akinesia, analgesia and hypotony are the main concluding anesthetic points where we have to look for because the surgery success will be depending very much on these components. So mostly if perforations are larger in size and cornea is not intact, then general anesthesia is the preferred one. If perivulvar, then small. In cases of small ulcers involving 6 millimeter or so, we can give perivulvar anesthesia also, but without any massage. And if there are small perforation, even tissue adhesive can be put at that perforation first, then block can be given. Surgical steps, self-retaining speculum can be put, but in cases if we are thinking that it is perforation and it can put pressure on the globe, then we can put the Flerenga ring also to avoid the scleral collapse. Even lid suturing can also be done. 360-degree peritomy is required if it is threatening the limbus at any point of time, and wet field cautery to achieve full hemostasis, and donor trephination is always done first. So donor size should be always 0.5 millimeter larger in size, but in aphakic eyes or if it is involving the limbus, 1 millimeter larger will be going. Corneoscleral buttoning should be done from the endothelial side, and even sclerokeratoplasty freehand, that is known as freehand cutting of the tissue, is required if they are larger in size. So donor cornea preparation prior to opening eye, it should be done, and straight vertical trephination should be done, and sizing should be larger. So recipient corneal trephination should be controlled trephination, and debulking of the material should be very gently, because damage to the iris should be avoided at all point of time. Even a small graft that already Dr. Prasher has told, D-shaped graft can be done, which allows presentation preservation of the normal limbus. So this is a small video showing the ulcer limbus to limbus. So we have to do this way, and we have to be very gentle with this. We don't know what we are encountering next. So then we are cutting. Then most important thing is we have to remove all those exudates in the interior chamber. Side port entry with the small, with a 15-degree knife that, and it should be then afterwards putting viscoelastic to push all the iris as well as other contents posteriorly. Then exudates should be removed, and then irrigation of the interior chamber with vancomycin, amphotericin B can be done depending upon the etiology. If it is already known, trauma to the crystalline lens should be avoided at all point of time, because it can lead to expulsive also. In cases of endophthalmitis, K-Pro assisted open sky vitrectomy can also be done. So this is another video showing these exudates from the interior chamber, and they are bridging that pupillary area. They should be removed very gently, and then for sweeping of all the angles for all these kind of thick exudates, they should be removed. Otherwise, recurrence will be the next thing to see. So donor graft placement should be done with after coating the bed with the OVDs, and transfer the donor to the recipient and avoid the endothelial touch at all the point of time when we are doing this. First suture is more important, and it is 12 o'clock. Then second suture is for the tissue distribution. Then afterwards we have to 4 cardinal sutures are pointed out which formed a hexagon. Suturing in cases of TPK, interrupted suturing is always required, 75% of depth, and there should be longer bites for a proper wound closure. So this photograph is showing all the steps, keeping 1 millimeter of healthy cornea around, which is having the infiltrate free zone, then cutting it, then pulling all the membranes which are present in the angles, and then putting the graft without touching the endothelium, putting 4 sutures, seeing the cardinal pentagon, and then putting all the sutures. If the sutures, if it is smaller in size, 16 suture will do. If it is larger in size, even 24, maybe more than that, sutures are required. So then recipient should be divided into 3 parts, one for staining, grams QH, one for histopathology, and one for culture. So these are few photographs of our patient. We have done that first is fusarium patient, and it has eventually got into failure. So first the photograph is having curvularia, and this is pre and post, and then aspergillus. All these are the photographs of the patients which we have already done. Complications of TPK are retrobulbar hemorrhage. If we are giving the blocks, globe perforation can happen, and even expulsive hemorrhage can also be seen, because it is an open sky procedure. Early complications are wound leakage, shallow interior chamber, uveitis, elevated IOP, and persistent epithelial defect, which is encountered within 15 days of the surgery. Late complications are cataract, graft failure, glaucoma, Candida infections, and even phthisis bulbi. Post-operative treatment is very important if you want to see the graft for a longer time. Preservative-free antibiotics, tear substitute should be given. No steroids if it is fungal for 2 weeks at least. Then afterwards we can start with. Then oral fluconazole 150 mg BD or itraconazole 200 mg BD if it is fungal. Anti-glaucoma and cycloplasics are always the part of the regime post-operatively. So visual prognosis and outcome of TPK, it depends upon that therapeutic successes if it is complete eradication of the infection after PK. And therapeutic failure is if it is recurring the infection after doing all the things. And visual rehabilitation is always the secondary objective. So risk factor for failure of TPK are if there is pre-existing glaucoma, the microorganism is worse like fungi or acanthamoeba, frank perforations are there, limbus involvement is there, excessive scleral involvement is there. So this is one of the paper of that is outcome of TPK in advanced infective keratitis, where we found that perforated corneal ulcer was the major indication of TPK, that is 55%. Then anatomical success was achieved in 85%, almost 86% of the cases, and therapeutic success in 89% of cases, and functional successes, that is visual regain, that was in 70% of the cases. So indication and complication, they significantly affect the anatomical, therapeutic, and functional outcome. So these are few photographs. So to take home messages, the earlier time of surgery is critical for good therapeutic outcomes because scleral and intraocular extension of the infection is likely to result in the poor prognosis. Recurrence is very much common in acanthamoeba and fungal, and meticulous follow-up for the success of the surgery is very much required. Thank you.
Insightful presentation. I would like to call upon Dr. Nitin Batra sir to present a token of appreciation.
Any question?
Thank you, Dr. Anuradha Raj, for a very detailed presentation. I think it's very useful for all of us, especially the residents, and you are doing wonderful work. Any questions from the audience, please? No questions? That means you understood everything, huh, students? Or nothing? Okay, thank you very much. Can you give the... Dr. Nitin is here.
Batra sir to give a token of appreciation to ma'am. I would also like to call upon Dr. Nitin Batra sir to give a token of appreciation to the chairperson, SM Bhatti sir. We request you to be on the stage, sir. And moderator, Dr. Gurvinder Kaur, ma'am. Ma'am, we request you to come up on the stage. I would like to thank all the distinguished speakers for enlightening us. With this, I would like to conclude the first session of the CME. Now, we'd also like to give a token of appreciation to the members of the organizing committee, for which I would like to call upon Dr. Simran Chawla, ma'am.
Good afternoon, everyone. I, Dr. Simran Kaur Chawla, on behalf of Department of Ophthalmology here at CMC Ludhiana, would like to call upon stage Dr. Nitin Batra sir to felicitate the organizing committee. First, I would like to call upon stage Dr. Reenu Thomas, Assistant Professor, Department of Ophthalmology. Dr. Samson Rajpal, Senior Resident, Department of Ophthalmology. Yes. Dr. Lexis Verghese, Resident, Department of Ophthalmology. Dr. Gurman Kaur, Department of Ophthalmology. Dr. John Jacob Matthew, PG Resident, Department of Ophthalmology. Dr. Rajat Solomon, PG Resident, Department of Ophthalmology. Dr. Eldo Elias, PG Resident. Dr. Lexus Verghese, PG Resident, Department of Ophthalmology. Dr. Priya Goel, PG Resident, Department of Ophthalmology. Mrs. Naresh Uppal, Mr. Pawan Kumar, Mr. Mandeep Singh,
And now we are starting with the second half of the CME. And with this, I would like to introduce our first speaker for this session. He did his MD from Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIMS, Delhi, and fellowship from LV Prasad Eye Institute, Hyderabad, and fellowship from LV Prasad Eye Institute, Hyderabad, and is currently working as assistant professor in DMC Ludhiana. He is also a member of the editorial board for Daily Journal of Ophthalmology and the winner of ISKRS Quiz 2017 in New Delhi. With his work in corneal tomography and biomechanics in primary pterygium published in the year 2017. With this, I would like to call upon stage Dr. Sahil Goel sir, who will be talking on prevention of corneal blindness and new innovation.
For this session, I would kindly call upon Dr. Rupali Chopra for the moderator.
Jitendra Kaur, ma'am, please, you are there. Request you to please be on the panel here.
I would like to thank Department of Ophthalmology, CMC, especially all hard work Dr. Nitin has put in, and for this wonderful gathering. The case I am going to show here is, I had a lot of trouble thinking about what to present after especially Dr. Namrata's talk. I knew she would be talking everything about corneal transplantation, lamellar component, everything. So I decided to present two things which I have worked upon in the last couple of years. Slight differences, slight innovations. I'm going to start with the first one. So this one was a young male, around 25, 30-year-old guy, who came with this perforation. One option for these perforations would be to a large graft, of course risking high risk of rejection and the suture-related complications. We have the option of just closing down this perforation. I'll be coming to these options for this kind of presentation. By the time the patient came, already the iris had started epithelializing, so even if he had left it like this, it might have sustained, but this was a one-eyed, this was the only seeing eye. I did not want to leave it like this. I wanted to give him a good, healthy vision without glaucoma, without rejection. So in an ideal world, it would have been something like a liquid matrix to fill this perforation with a matrix and then let it epithelialize, but we do not have it yet. What are the options we have? We have grossly two options: overlay graft and inlay graft. We can either cover this perforation with one of the biological materials. Most often we use cyanoacrylate glue, but that cannot be used for more than 2 mm perforation, or it makes it difficult. This perforation, we had the option of using conjunctiva, amniotic membrane flap, or tenons as an overlay. Overlay has the problem that once you do it, the surface is very irregular and opaque. The second option is inlay, that is, you fill in the perforation with some material. Most often being done is tenons patch graft, but that is extremely irregular, gives astigmatism, does not give good vision. To get a good anterior surface, we require something which can gel in with the anterior surface of the cornea, which gives us two options of sclera and cornea. Sclera, of course, is opaque. Cornea, though is transparent, a corneal patch graft would run the risk of rejection. So once you have transplanted the endothelium, there is always lifelong risk of rejection. The patch might turn white, which will dampen your efforts to visually rehabilitate. What I tried in this case was anterior lamellar patch graft from what is otherwise a trash, the patch left from DSEC cap, as was also shown by Dr. Pavan. So normally when we do this anterior lamellar patch graft with the DSEC, again we can do the patch graft like this, but the problem is the full thickness patch ultimately undergoes rejection and turns white. But in my case, I used anterior lamella without endothelium, and with this I would like to show this video.
Begin with loose epithelium over the bulging iris was peeled, an anterior chamber formed with visco. 360-degree groove is created around the perforation site with help of a crescent to tuck in the lamellar patch graft. Trimming of peripheral edges of 3.0 mm patch derived from 8.0 mm cap left over after decimate stripping epithelial keratoplasty done.
So, as you can see here, this perforation, the patch which I had fashioned 3.0 mm, I could not fit it in. Everything I tried to fit in, it kept out.
Despite multiple attempts, the anterior lamellar graft continued to extrude from the perforation site.
So, two main challenges are how to keep the graft in place, prevent graft extrusion, and second, how to customize the graft to exactly fit the perforation site. For first problem,
So normally we take the sutures through the graft to keep it in place, but this case I tried to do what are overlay sutures, that is sutures above the graft. Imagine there is water leaking through a pipe and you're trying to plug it with your hands, you're just trying to push and plug the hole. So similarly, I have passed sutures above the graft so that it keeps the graft tucked into place instead of passing the sutures through the graft, which tends to decrease the astigmatism. So
and second, how to customize the graft to exactly fit the perforation site. For first problem, we use two bow-shaped overlay sutures, similar to crossed horizontal mattress, that prevents the graft from extruding. For the second problem, we go back to preschool. Remember, how keep...
Okay, so first was this bow-typed suture over the graft. I took two perpendicular ones before putting the graft. For the second thing, we hand fashioned the graft, just like art and craft. Imagine a child has been drawn this line on a piece of paper and the child custom cuts this paper according to the line drawn. Similarly, I put with a marker dotted line exactly where I was supposed to cut it. I'm not able to pause it here.
Then cut it with the surface of its second lines. On similar lines, we mark the sponge-dried posterior surface of its cap, capped onto the perforation site. Then cut it with venas, like in art.
So as you can see here, after marking with the blue marker with the Sinsky, I know where exactly to cut, and now with Vanas I am cutting the dissect cap exactly where I wanted to, so that I have a customized graft meant to fit this perforation exactly in size.
In craft classes. Now this custom-made graft is fit inside the perforation and second overlay suture applied. In the end, graft surface is dried with cellulose sponge and amniotic membrane with fibrin glue applied in order to promote epithelialization. Excess edges of amniotic membrane trim.
To promote epithelialization of this graft, I additionally applied amniotic membrane with fibrin glue, which was not essential but was just for my peace of mind, so that it epithelializes rapidly.
And bandage contact lens applied.
So this is how it looked at 1 week post-op. These are 2 overlay sutures. This is at 2 weeks. The visual acuity had already improved to around 618. By this time, the vision had improved, the amniotic membrane had dissolved, the BCL I had removed, and the visual acuity by this time had already improved to 6.9 at 3 weeks. This is how the ASO looked like. In the center, there was some thinning apparent because the dissect cap was less in thickness. But the beauty of epithelium over a graft is it tends to sort of mitigate or mask any irregularities, and gradually this epithelium filled in this gap. So this is how it looked at 4 weeks. At 1 month, I had removed the first suture, and ultimately I removed the second suture at 2 months. I do not have the photograph right now, I'll be showing you soon. At 2 months, I removed the second suture also. So what I ultimately have is a suture-free 6/6 uncorrected vision at 2 months post-op. So this is another such patient in which there was a perforation, but here because the size of the perforation was larger, I could not use overlay graft, so I had to use interrupted sutures, ultimately giving the same 6/9 uncorrected vision. With this, I would like to end the first part of the presentation. Let me see if I have the 2-month video also. Yeah, I think this video did not go through. So this is what I try to show you, that if you have sort of a hole in a wooden plank, I think that's the reason we generally prefer our own laptop, but it seems that Mac was not working here, not getting connected. Let's try again. This video. Duplicate.
Window P.
Okay, got it. Okay, so actually ideal would be if you have a perforation like this wooden log, like a carpenter does, put some resin over onto this. This is what Dr. Sangwan has been trying at LV Prasad and now at Shroff, to have a liquid biometrics which can be poured into a perforation and then smoothened all over it, so that you can finally have a perfect finish without ever knowing if there was a perforation. But right now we do not have that option. So coming back to our case,
bulging iris was peeled in anterior chamber.
So this was at 1 month, and at 2 months, this is how it looked like. You can hardly make out if there was at all a perforation. There is a lifelong steroid-free, uncorrected 6/6. To achieve this kind of uncorrected 6/6 in a one-eyed patient without steroids, without antibiotics, without anything else is sort of a dream come true, especially for a one-eyed patient like this. With this, I would like to go to the second presentation. Okay, so we have been talking about corneal transplantation, and I thought let's talk about a case scenario where transplant cannot be done. Stephen Johnson's, it's been more than 100 years. 1922 is when American pediatrician Stephen and Johnson's first described this condition. In acute stage, it looks debilitating like this diffuse sloughing of skin. There is sloughing of mucocutaneous junction as well as of the conjunctival epithelium. This is true peeling of membranes like pseudomembranous conjunctivitis. This is one of the most dreaded conditions, ophthalmic conditions to treat with. And untreated, this a lot of times goes on to such chronic cicatrizing conjunctivitis. The eyeball entirely becomes scarred and vascularized, and this is one indication where transplant cannot be done. So what is the treatment? The right treatment would be to prevent such a complication. So prophylaxis or prevention of these complications is what we are running after. And the only level 1 evidence till date exists from Dr. Namrata Sharma's group is a randomized trial showing and comparing amniotic membrane without amniotic membrane in acute Stephen Johnson's. For this, what originally was described almost 15 years back was from Dr. Gregory. He used multiple sutures to hold the amniotic membrane in place. Following this, Dr. Shodosh started this tube but still had to suture. The problem with sutures is that these severely sick patients had to be taken to ICU. To get journal and CR clearance was extremely difficult. So what we slightly modified this technique was, when we see this kind of true peeling, we tried to do a bedside technique for amniotic membrane grafting. No sutures, no glue, no anesthesia, just plain bedside technique. So we take an infant feeding tube, 9 centimeters, using a simple formula of 2 pi r, that gives us a ring diameter of around 30 centimeters. We enlarge the female end, taper the male end, fit the tapering end into the dilated female end and make a perfect ring. The beauty of this ring is, even if it is slightly larger in size, it will become horizontally oval. It will fit perfectly into the fornices. You always will be able to decrease or prevent symplectron formation. Next, you take a 10 into 6 centimeter amniotic membrane and wrap it around the ring. The rectangular part, the shorter ends, you wrap first because that is what is going to cover the lateral and medial canthus. The longer ends you fold onto the ring later because you are going to unfold that on upper and lower lid first. So what is to be unfolded first is to be also folded later. So these are the two ends, and then you put back the two ends onto the ring. So now this ring is ready. This ring is what we prepare in the operation theatre and then carry it in a kidney tray or any sterile tray to the operation theatre, to the bedside. The patient does not have to be wheeled in. It's absolutely painless. You take a Desmas retractor. With just a plain index finger and thumb, you insert this into the upper fornix. Once you have pushed it in, this is under topical anesthesia, Paracaine, that's all. You have covered the patient's eye with the sterile cover and pushed the ring into the upper fornix. Now similarly, you retract the lower lid with the Desmas retractor. With the index finger or cotton bud, you just stuck in the ring inferiorly in the fornix also. Voila, without anesthesia, pain-free, bedside amniotic membrane has been inserted into the patient's eye. Now how to make sure the amniotic membrane stays in the eye? Well, the beauty is once you have trimmed the lashes, a lot of times there is bare dermis exposed, the amniotic membrane sticks very beautifully to the skin. So you just have to unfold the amniotic membrane and sort of iron it all around the eye. So first I have unfolded the upper half, now I'm unfolding the lower half, and finally the medial and lateral canthus. The beauty of this technique is it is so simple that now my first year does it without me ever having been taught her this at all. She just saw the video. Last 2 months she has done 5 amniotic membrane grafting in acute SGS. So coming to the advantages, coming to the results. So this ring is taken to the bedside. This was one such patient. We put the amniotic membrane. You see immediately after the amniotic membrane procedure, the eyes are wide open. The beauty of this tubing is that it has barium embedded into it. It is X-ray opaque, and probably you can see here, this one is the ring here. So this is the orbital rim, and this circle, this one, this is the amniotic membrane tubing inside the eye. So sometimes the patient is lost to follow and comes back again after 1 month. You can still see this ring here, whether it is retained inside the eye or not. So in our case series, we realized that majority of these patients were because of anti-epileptic. Around 40 patients, 40% were because of anti-epileptic, and another 20% were because of allopurinol. 40%, 60% do not require intervention because they do not develop a stain positive area. It's only 40% who require a stain positive area. So in our series, almost 18 patients require amniotic membrane grafting over a period of around 4 years. This is the spreadsheet showing the results in which there were 2 mortality and 2 were lost to follow-up. Only one data exists before this from the Boston group, Dr. James Shudosh, which shows that almost 90% of the patients can preserve vision better than 660. This is something which we shown in our case series also. Visual acuity better than 660 in 90% of the eyes. In Stephen Johnson's, this is something which is relatively unheard of. Though patients do require a lot of adjuvant procedures in terms of medical management, it requires mini scleral lenses, surface stabilizing procedure with autologous serum and systemic immunosuppression. In terms of surgical interventions, it requires amniotic membrane repeated for PED, tarsography. Chronic sequelae requires mucous membrane grafting, and sometimes later it requires keratoprosthesis also. But beauty was we were able to avoid any such transplantation or keratoprosthesis in entire case series of our 40 plus patients in last 4 years. Chronic sequelae otherwise included keratinization, hyperemia, neovascularization. Almost 30 to 40% required mucous membrane grafting somewhere around 1 to 2 years. So this technique has the advantage that there is no suture, no glue, no anesthesia, no expensive equipment. There is a customized availability of the tubing. You can custom fit the size of the ring to fit the eye perfectly, whether it is a pediatric case or an adult case. There is absolutely no cost. There is absolutely no learning curve. So you are able to get 90% of the patients, prevent legal blindness in 90% of Stephen Johnson's patient using this absolutely cost-free technique. With this, I would like to end this presentation. Thank you very much for your patient hearing.
Thank you, Dr. Sahil, for a lovely presentation. I'm sure your innovations would actually inspire a lot of people to take up ophthalmology and especially cornea as a subspecialty. I think the best part is your innovations are something which has made it easier, as in, you can do it in a tertiary hospital. These things can be done at the bedside. As you said, it's very important that you can do it at the bedside with no sutures and with no anesthesia. So I think they'll go a long way in rehabilitating a lot of our patients. Thank you so much. Any questions from the audience, please?
So Dr. Sahil, how long do we need to keep this?
So the ring has to be removed between 7 and 10 days. On an average, we require to do amniotic membrane between 6 and 10 days. Generally, first 5 days, I have realized the Stephen Johnson's patients do not require amniotic membrane because the surface does not break down in first 5 days. It's the skin, the lid margin, which starts breaking down earlier. Like yesterday only we did amniotic membrane. We had been following that patient in skin ward for last 5 days. On day 8 is when the cornea and conjunctiva started breaking down, and that's when we applied this amniotic membrane grafting. The ring should be removed ideally before discharge. Generally, the amniotic membrane dissolves within 7 to 10 days after insertion. There has been only one patient who was discharged earlier, took discharge against medical advice drama, came for follow-up after a month. But even that patient, we were able to remove the ring by cutting the early symphysis which had formed, thereby enabling us to get deep fornices in most of these patients.
Thank you.
Thank you.
Any questions, please?
Now I request Dr. Nitin Batra sir to present the token of appreciation to Dr. Sahil Goel sir. We are honored to have Dr. Abjinder Kaur, Punjab Medical Council representative in our midst. Thank you, ma'am, for gracing us on this occasion. We acknowledge the presence. We acknowledge your presence, ma'am. Now we acknowledge the presence of Dr. Sumit Chopra, Professor and Head of Eye Department, DMC Ludhiana. Now, for our second speaker, she did her graduation from Jawaharlal Nehru Medical College, Wardha, Maharashtra, and MS Ophthalmology from MMU Mulana, Ambala in the year 2014, and did her fellowship in cataract and refractive surgery from Dr. Om Prakash Eye Institute, Amritsar, Punjab, and also in cornea and microsurgery from Arvind Eye Hospital, Coimbatore, Tamil Nadu. She is currently working as cataract, cornea, and refractive surgeon at Rajendra Eye Hospital, Ludhiana, and visiting cornea surgeon in CMC, Ludhiana. She has exceptional experience in managing corneal diseases and pathologies and doing corneal transplantation surgeries. She also has numerous publications in different Indian and international journals, the latest being a 5-year review of co-infection in acanthamoeba keratitis from South India. With this, I would like to call upon Dr. Shefi Badwal ma'am to give an overview of corneal blindness and eye donation.
Thank you, Dr. Batra sir, for organizing such a lovely oration. Today, we have all discussed about cornea transplantation and its recent advances, but I'll be talking about an overview of corneal blindness and basics of eye donation. So, eye is a wonderful creation of nature and a masterpiece of perfection, and this is one of the most precious possessions. So even if we lose partial or total vision, so this is one of the biggest tragedies. So even if we lose one of our legs, we can walk again with an artificial one. But without sight, it is very difficult. Can you imagine your life with darkness? No, it is very difficult. So it is the causes of blindness in India are cataract being the most biggest one with 62.6%, followed by refractive errors and glaucoma. The corneal blindness covers 1% of this. The causes of corneal blindness encompasses a range of eye conditions that alter the transparency of the cornea, that cause corneal scarring and eventually blindness. The corneal ulceration and corneal trauma, they cover the most common one, followed by trachoma, vitamin A deficiency, hereditary problems, congenital diseases, and chemical burns. Globally, 39 million people are completely blind, and India contributes around 30% of the blind population. That is around 13 million. That is approximately 1% of the total population of India. That is 1.2 crore people. In India, it is estimated that there are approximately 6.8 million people who have vision less than 6/60 in at least one eye due to corneal disease. Of these, about 1 billion have bilateral involvement. According to NPCB estimates, there are currently 1,20,000 corneal blind persons in the country. And according to this estimate, there is addition of around 25 to 30% corneal blindness cases every year. Out of this 1.8 corneal blind people in India, around 1 million are only children. So we have already covered in the previous sessions also that annual requirement in India is around 1 lakh, but the annual collection of eyes is only 22,000. And the keratoplasties which we are doing per year is only 8,000 to 9,000, which is only 40,000 of the utilization. So where is the problem? The problem is there is inadequate eye donation. So what is eye donation? It is an act of donating one's eyes after his or her death purely for the benefit of the society. It is an act of charity for the benefit of the society. It is totally voluntary, and the only cornea blind people can be benefited from it. the eye banks provide the donated the cornea, and race, sex, age, the blood type, eye color, any of these things are not considered in selecting the donor because they are not affect the outcome of the cornea transplant surgery. What are the main barriers that affect the collection of the donor eyes? These are inadequate public awareness, insufficient facilities in the institutes and hospitals, absence of motivation even among the trained personnel, and social and religious myths. Coming to some myths and facts about the eye donation. The most common myths are cornea transplantation is an experiment procedure. No, it is a very proven and routinely performed surgery, and it is a very successful procedure. And this is one of the most common procedure where the chances of rejection is very less rather than the other organ transplantations. Then people also think that Indian eyes are not good to be used for corneal transplantation, whereas the fact is eyes of any deceased person anywhere in the world can be used for corneal transplantation, but only after evaluation. People think entire eye can be transplanted. We see people coming in the OPDs and asking, even the patients who have retina problems, they think that the whole eye can be transplanted. They ask us that take the eye out and the whole eye can be transplanted. The fact is only the front portion of the eye, that the cornea, that is the only part that can be transplanted. The myth is eye donation interferes with or delays customary final rites, whereas the whole procedure takes only 15 to 20 minutes. So it does not delay with any of the rites during the death. Eyes can be removed out of the living human beings. No, that is not correct. Eyes can be removed only after the death. Human eyes can be bought or sold. No, selling or buying of human eyes is illegal. Only those who have pledged their eyes can donate them after death. Pledging of eyes is not important. Even if you have not pledged your eyes, or if you have or you have not, does not matter. The consent of family member is very important, without which your eyes cannot be removed. After your death, the consent of the family member will be taken, after which only your eyes will be removed. It's a myth that eyes of aged donors are not acceptable. All the donor eyes are acceptable, irrespective of age and sex. People also believe that if you donate your eyes, you will be blind in next birth, which is not true. It's an act of charity, and that is bound to earn blessings. So what needs to be done? Eye donation awareness activities need to be done, for which we have eye donation fortnight, which is observed annually throughout the country to promote the pledging of eye donation, and cornea transplantation, which we have already discussed in the previous talks. Eye Bank is a charitable organization without any profit motive. It facilitates the removal, processing, and evaluation of eyes. It distributes them to the persons in need of transplantation. So we have these pamphlets available in the eye department, which have all the frequently asked questions, and also there's a pledge form. Whoever wants to pledge their eyes, or anybody whose relatives, anybody wants to pledge their eyes, can fill the form also. So there are a few contraindications for eye donation. Who cannot donate their eyes. People who have infectious diseases like AIDS, active encephalitis, endocarditis, hepatitis, syphilis, infections like septicemia, malignancy like leukemia, neurological disorders, or neurodegenerative eye disorders like intraocular infections, which were active at the time of death, malignant tumors, corneal disorders which affect cornea like keratoconus, keratoglobus, any disease affecting the cornea like corneal opacities, pterygium, any scarring of the cornea, any corneal surgery done like radial keratectomy. So these patients cannot donate their eyes. So the surgical retrieval for the eye donation, this can be in the form of enucleation, where the whole eyeball is removed and then this is brought to the eye bank where the tissue corneal button is made. Also the cornea, sometimes corneoscleral rim is only removed from the body. This can, so this procedure can be performed either in the operating room or the morgue, hospital room, or even in the funeral room. Some of the instructions for the relatives, they should switch off the fans, they raise the head of the deceased by about 6 inches, ensure that the eyelids are properly shut, and place a clean wet cloth over the eyelids so that the cornea does not become dry. Do not put any religious material over the eyes or face of the deceased. Inform the eye bank as soon as possible, and also keep a copy of the death certificate if possible, so that we can know what type of death it was. After donation, the donor's family will receive a certificate of appreciation from the eye bank. Eyes are evaluated from the eye bank, and only the ones suitable are used for transplantation. Others are used for research and education. The recipients are notified on a first come first served basis from the registry. The donor cornea is stored in moist chamber where it is stored only for 24 hours. For 2 to 3 days it can be stored in a medium, MK medium, and for long term storage it can be used in nutrient medium. So eye never dies, so we need to donate, says yes to eye donation. Thank you.
Thank you, ma'am. Now I request Dr. Nitin Batra sir to give the token of appreciation.
Thank you, Dr. Shafi, for a very nice session. I think that's very important about eye donation. In the morning sessions, we realize that all our surgeons are trying to find ways and means to do a maximum utilization of the available corneas. So for one cornea, they are transplanting or giving vision to 3 people. So that is one aspect. The other aspect is eye donation. So as students, as part of the health industry, I think it's our duty, our job, even if you're not a part of the eye department, you should be knowing about eye donation and encouraging as many people as possible to pledge their eyes. Thank you, Dr. Shafi. Any questions?
Our next speaker is a young budding ophthalmologist who did his graduation and post-graduation from CMC Ludhiana. During his study years here in his alma mater, he was known as exceptionally bright and promising student. He is presently completing his fellowship in L.V. Prasad Eye Institute, Hyderabad, and he has been actively involved in various presentations and publications, and as the member of the organizing committee of national and international conferences. With this, I would like to call upon Dr. Rohan Kapoor sir, who will be taking us through a challenging case of fungal keratitis.
Hello. Hi, a very good afternoon to each and everyone present here today. At the outset, I would like to thank Dr. Nitin Batra sir and the entire Department of Ophthalmology at CMC Ludhiana for organizing the wonderful oration. It's a moment of pride. It's a privilege for me to come back to the institute which actually has taught me the science of medicine. I have grown through my MBBS and my MS listening to stalwarts in every field presenting from this very podium, where I'll be presenting this case I don't have any financial disclosures. I wish I had. I would also like to thank Dr. Somshila Murthy and Dr. Brijesh Thakkar. They are my mentors and they helped me guide through this case, and they managed this case at LV Prasad Institute, Hyderabad. Now the objective of my today's presentation is to project how immunosuppression due to any cause, be it systemic or local, can lead to rapid worsening of a case of ocular infection. My case is a 56 years old male farmer who came with sudden worsening of vision in his right eye after he had trauma with rice husk 1 week back. The important part is that he had no comorbidities. However, he had COVID-19 infection 1 month back, received multiple injections of steroids while undergoing treatment for COVID-19, and his visual acuity at presentation was being PL positive with PR being accurate in the right eye. This is the slit lamp photo at presentation. What we can notice is that there is a superior oval stromal infiltrate. Just a second. Okay, we don't. Yeah, so we can see there's a superior oval stromal infiltrate which is measuring 6 into 5 mm, almost involving the limbus in the superior part of the cornea. And there are inferior endo-exudates at the presentation. As the media was very hazy, we went ahead with a B scan which showed an anechoic vitreous cavity of the right eye. A corneal scraping was taken from the ulcer and it was sent for gram stain KOS calcofluor white stain which showed septate fungal filaments under fluorescence microscope. The patient was diagnosed with right eye fungal keratitis and he was started on topical natamycin, topical atropine, oral ketoconazole 200 mg BD, the standard treatment. However, in spite of being strictly compliant with his medication, 3 days later, he presented with worsening of his symptoms. We could make out that the lid edema had increased. His visual acuity was still the same. Infection had progressed to involve the entire cornea of the right eye. And the B scan now did show membranous echos in the vitreous cavity, which you can make out, and the corresponding A scan showing low to medium eporeflective spikes. The patient was going into endophthalmitis, and we had to go ahead with a right eye therapeutic penetrating keratoplasty with an intravitreal injection of voriconazole. Intraoperatively, while operating, lens was filled with exudates. It was bulging anteriorly. We took a 12.5 mm graft, 24 sutures were placed, and ICCE with anterior vitrectomy was also done. The patient was followed over next 2 weeks, being kept on topical and oral antifungals, and this is the slit lamp photo post 2 weeks. The infection still progressed. His visual acuity was PL positive, PR accurate, IOP being 7. We can make 24 sutures being intact. The graft had edema. Centrally, if you can make out, there's a 6 mm epithelial defect. AC was filled with hypema and hypopion. And the B scan showed increment in the membranous echos in vitreous cavity. Again, corresponding low to medium echo-reflective spikes. And there was development of choroidal detachment also at this presentation. After discussing with the fellow retina consultant, we decided to go ahead with an AC wash, pars plana vitrectomy, fluid air exchange with intravitreal injection of amphotericin B. Intraoperatively, the blood and exudates were washed and the preretinal exudates were removed to the extent possible. While performing penetrating keratoplasty, half of the corneal sample is routinely sent for microbiology as well as for the histopathological growth. Now, microbiology showed growth of this velvety colony with an orange tinge in potato dextrose agar, which was identified as Fusarium solani. And histopathology showed very deep corneal involvement, ulceration. There were fungal septate hyphae present till Descemet's membrane. And so, we continued the patient on oral and topical antifungals. This is a slit lamp photo post 4 weeks of therapeutic PK and 2 weeks of pars plana vitrectomy. Vision same, PL positive, PR accurate. However, the patient had started responding. We can see that the sutures are intact. The graft was much clearer as compared to the last visit. The epithelial defect had almost resolved. You can see there is retraction of hypopion. The AC is not much filled with blood and pus anymore. And the B scan also showed much improvement in the membranous echos in the vitreous cavity. It was almost clear. However, choroidal detachments were still present. There was still retinochoroidal thickening present. I don't have a slit lamp photo available for this visit, which was post 6 weeks of therapeutic PK. However, at this visit, his vision had improved to hand movement. There was clearing of graft. There were no signs of any infiltrate. Epithelial defect had healed. B scan showed very few echos in the posterior segment. some retinochoroidal thickening, and now we decided to start the patient on topical prednisolone Q2 early at this stage. But what we did not expect was that 3 weeks later, he presented with sudden onset of pain in the right eye. His visual acuity was PL positive, PR accurate. We noticed the involvement of the cornea, mostly posterior involvement, but you can see that the infection had again, recurred or residual infection in the superior part of the cornea. We were discussing if this is actually a recurrence of the infection or if this is residual infection, because again the superior part of the cornea was involved. The B scan again was done, showed multiple medium, low to medium echo-reflective spikes suggestive of vitreous hemorrhage along with exudates in the vitreous cavity. We performed an AC wash, gave patient another injection in the vitreous cavity, but he did not improve. The infection kept on progressing to occupy the entire cornea, and as last resort, another repeat therapeutic PK was done along with the vitreous lavage and IOAB. This is the last slit lamp photo I have of the patient. The infection had resolved, but the eye was already shrinking, going into phthisis. B scan findings were suggestive of VH with subchoroidal hemorrhage. If we deep dive into the literature, what we'll find is that fungal keratitis can worsen rapidly if it is associated with predisposing factors such as trauma, topical corticosteroids, use of IV steroids, or even uncontrolled diabetes mellitus. Therapy for COVID-19, it involves systemic glucocorticoids along with other agents for acute respiratory involvement. Now, our patient developed this infection 1 month after having COVID-19 and received IV steroids. Fusarium infection is itself a very fulminant organism and has a poor prognostic, very poor prognosis. So we postulate that the use of glucocorticoids in COVID-19 may have been a risk factor, additional risk factor I would say, for poor outcome in our patient. The points of discussion which I have in my mind while presenting this case is that does systemic immunosuppression, does it actually play a role in worsening of keratitis to end off? Because our patient actually received IV methylpred around 3 weeks prior to his presentation. And a very important question I have is that how long actually do you wait to start topical steroids in a case of therapeutic PK for fungal keratitis with end off? A patient who's actually not able to, the ED is not healing, the infiltrates are still present. And I also think that maybe we had to do an ICC with anterior vitrectomy. We had to make the eye a single cavity. Did that actually predispose for him to go into end off from keratitis? Thank you so much for your kind listening.
Thank you very much, sir. Sir, I request you to please be on the stage to receive the token of appreciation. And now I would like to call Dr. Abjinder Kaur to address the audience.
Very good afternoon to all the seniors, my colleagues, and my all juniors. And first of all, I would like to express my regards to the chief guest, Dr. Nimita Sharma, and welcome to her. And I would appreciate to Dr. Nitin Batra, and this thank you so much for this honor. I have been given for this. Thank you so much for the organizer of this function also. As the Safi told, there is without eyesight we cannot live. So we are very thankful to all the ophthalmologists. They are boon to us from God, and you all deserve a round of applause. And I would like to say something about me. I am Dr. Abjinder, MBBS MD. After doing this graduation, post-graduation, I joined the Punjab PCMS, and Then in 2020, government nominated me as a Punjab Medical Council member. Now I am the executive and this ethical member of this Punjab Medical Council. And here I am to give you this 4 credit points for the CME. And you are most welcome. If any problem in registration or renewal or updating of this, I am always help you. Thank you so much.
Thank you so much, ma'am. Now I request Dr. Nitin Batra sir to give a token of appreciation to the chairperson, Dr. Jatendra Kaur. And moderator, Dr. Rupali ma'am. And now we would like to give a token of appreciation to the members of organizing committee, for which I would like to call upon Dr. Simran Chawla ma'am.
I would like to call upon stage the following members of the organizing committee: Ms. Sathira Saji, Mr. Muhammad Yaqub, Mr. Muhammad Yaqub, Mr. Ayush Sharma, Dr. Abhay Kumar, Dr. Ajay Samuel, Ms. Ria George, Mr. David Thomas, Mr. Akash Kumar, Mr. Karan, Dr. Karan, Dr. Aileen, I would like to call upon stage Dr. Gurvinder Kaur ma'am to facilitate the BSc Optometry students and interns. Ms. Kanchan Rani, Mr. Thaminder Kumar, Ms. Nikita, Ms. Pooja, Mr. Aman Chandra. Ms. Sunaina Rajput. Mrs. Jaspreet Kaur. Mr. Happy. Mr. Lavish. Mr. Aditya. Mr. Lavneesh. Ms. Jaspreet.
With this, we conclude the CME. Now I request our guests to please proceed for lunch, which will be followed by a wet lab cum workshop conducted on the second floor of Department of Ophthalmology. Thank you.